first of all, advising everybody in the public gallery, you're all very welcome. Certainly, this is the biggest crowd I've had in my time as Health Committee Chair. So you are welcome to use mobile devices as long as they're in airplane mode. Please keep them muted. It's not permitted to take photographs or record any of the meeting. The meeting will be recorded and sent out live. So if there's something you want to catch up on later on, you can get it on the website. So I'm just going to begin. And say welcome everybody here. Our first briefing session, we have Alan Millburn. Alan, you're very, very welcome. Alan is obviously a former British Government Health Secretary. He is currently the lead DHSE non-executive director within the Department of Health and Social Care. So we're delighted to have you with us in the Health Committee, and I know that you have strict time constraints, so we'll have you away shortly after 3 o'clock. So
thank you.
I'm going to hand over to yourself if you want to give some brief introductory remarks, and then we'll have some questions from the members.
Great. Well, thank you, Chairman, and thank you, everyone, for being here. I mean, just very briefly, just to talk a little for a moment about where healthcare is, certainly maybe from a point of view of what's going on in England and how you go about the process of fundamental change. Because this is the challenge that every healthcare system in the world is facing. Okay. Because we are up against a whole series of both challenges and, frankly, we also have the opportunity to harness some really big potentials for change. So reform, as here, with the reset plan that the government has here, is typical in one sense about what is going on in healthcare, which is everybody's looking to move away from the current system towards a new system. The question is how you do it, because it's hard. And it's hard for a reason, which is that healthcare matters to everyone. It matters to every single citizen, matters to every patient, it matters to the people working in the system. And so I would say there are 3 or 4 ingredients that certainly when I've done big change programs in health during my time as Health Secretary and now advising Wes Streeting, the current Secretary of State in England, the first is you've got to sort of really be very, very clear about what is the problem that you're trying to fix. And although people talk about healthcare being broken, it's actually broken in 3 different ways. First of all, the business model's broken because the money, which has been growing exponentially over time for healthcare systems, including the National Health Service across the world, the money is running out. It hasn't run out. And so there's a limit to how much you can keep investing. And particularly if you're putting more and more money in and you're not getting corresponding improvements in productivity and efficiency, which is what's happening. And so that business model, if you like, is broken. The second thing that is broken is what I call the operating model. In other words, the way that the system is organised. And certainly in the case of England, I can't speak so much for here, but in the case of England, it's still run pretty much like an old-style nationalised industry. This is a thing that employs 1.6 million people. You can't run it from an office in Whitehall, because where the innovation happens, where the creativity happens, and where the rubber hits the road is in local systems. So we've got to find a way of disaggregating that, if you like, that national model towards something that is much more, in my view, locally controlled, where there's much more empowerment for people working at the front line and much more community input as well. It doesn't mean that you don't have national standards or a national framework, but you need that. And the third thing, and this is the fundamental thing that I think people in the debate about healthcare keep missing, because there's a lot of focus on how you change structures, how you change organisations. The fundamental thing that's broken is the care model, the model of care. Because what we should be doing is trying to enhance people's independence. And what we are doing, almost inadvertently, is increasing dependence. And so you think about old age, for example. If you ask any poll of older people, when you ask them a sort of difficult question about where people would prefer to die, they always say at home. And where do people end up dying? In a home, not their own, or in hospital. So we've got to change that, in my view. And you've got now the tools to do it. This is the big opportunity that we've got, because technology is changing everything. So the first thing is work out where you are, what the problem is that you're going to fix. The second thing is, where are you going? Where are you trying to get to? And this is where I really think it's very important that almost you take a sort of future back view. Because the big thing that is changing healthcare across the world is technology. And it is this collision, if you like, between data analytics and genomic science that opens up quite a different vista for healthcare in the future. Our healthcare system has basically been based on the notion that we'll diagnose an illness and then we'll treat it. But what AI and genomic science means is that we should be able instead to move to a system that predicts and prevents our health. This is very different. It's a different model of healthcare for the future. And so if that is the destination where we're able to do that, and if it's a destination where the individual, the patient, has greater locus, greater responsibility, greater control, more choice for the future, how do we make that happen over a period of time? That's a big change from where we are today. So the third ingredient, I think, of successful reform is buy time. Whenever I'm asked by any health minister anywhere in the world what advice I would give if you're going to do a big change management program, it's always buy time. Change usually takes twice as long as you think. It's just hard because systems are ossified, processes are well established, cultures are pretty set. And so it's not a coincidence that in the case of the 10-year plan for health in England, it is just that. It's not a 3 or 4 or 5 year plan. It's not a plan for a parliament. It's a plan for 10 years because it will take that long. So that's the third and critical ingredient. And the fourth ingredient is an obvious one, which is if your objective is to move towards a very different system of care where you are better able to predict, prevent illness rather than simply treating health, you've got to make sure that that objective is aligned with the levers of change that you're putting in place. And that means some quite fundamental changes to the way that the system is architected, organised, structured, to how money moves around the system. So in our case, in England's case, money moves around the system to reward activity. So we incentivise hospitals to do more activity, which is great to get waiting lists down. But what we really need to be doing alongside that is making sure that the incentives are working in such a way that they are keeping more people healthy and out of hospital. And we know that today, in England at least, I don't know what the data is here, but between 1 in 4 and 1 in 5 people who are in hospital tonight shouldn't be there, because we should be treating them and diagnosing them earlier. And the thing that I learned above all else as a health secretary, the most impactful measure, tool that you have in the box is the way that you use money to recognise and reward activity. So we can drive waiting lists down, of course, through doing more surgery and more interventions, but we've also got to stem the flow of people into hospital. And that means intervening much earlier, getting upstream, making sure that our community and primary care services are set up for the future, and our new services, which are going to be tech-based, whether that's genetic testing at birth, artificial intelligence, that they are being utilised in such a way that they are stemming the demand into hospital. So when you're looking at reforms, I would say these are 4 of the building blocks. As a committee, you should be interrogating your ministers and your senior officials about whether these 4 building blocks are there, because they are the ingredients that unlock success.
Okay, thank you. There are an awful lot. I'm not sure we're going to be able to do justice to that in the short time we have available. So, I mean, your last point when you were talking about intervening earlier and intervening upstream, I mean, the Minister talks about shift left, so essentially, so in terms of, you talked about using AI and technology, but how do you start shifting services out of secondary care into the community?
It's really hard, it's really difficult, because the system is running here and in England, it's running very fast and very hard. It's running very hot, which is the phrase that you'll hear in the NHS continuously. And trying to liberate cash at a time when there isn't a lot of it, in order to take a pot of money from here in a system that's running really hot and putting it into somewhere else, which might be a really efficient, productive, sensible thing to do and good in terms of clinical outcomes, is just really difficult. And what certainly, again, from the English experience, and this has been a failure, not a success, over a decade and a half, ministers have exhorted the NHS to spend less in hospital and more in community. And guess what? Precisely the reverse has happened. So we know that exhortation doesn't work. So the 10-year plan, again, commits us to spend proportionally over the course of the plan, proportionately less of the overall cake of healthcare expenditure in the community rather than in hospital. So that's a shift of resources, because we're going to have to do that. So, and that's not going to be easy when budgets are fiscally constrained, but that is what we've got to do. And a lot of the trick here is really about how we digitalize and how we get better intelligence so we know, look, we should be able to predict which parts of the population are going to get ill and which are not. We should be able to do that increasingly. And then we've got to make sure that the incentives are, again, aligned in the community so that GPs and other community health services are intervening amongst those populations. So those are some of the things that we need to do, but it's obviously an extremely difficult thing to effect when resources are tight. And I can't see a scenario going forward where resources are not going to be tight. I mean, here you're spending, 50% of your overall budget or more already on the NHS, and there's a limit.
And I mean, we had a conversation over lunch about invest to save, and I mean, you've answered some of that, because every time we're at the committee and we're out engaging with the health sectors, we're speaking about things that will help in the long term, but they require investment, and the health minister says he doesn't have investment. So there's always this conflict between what potentially might save money long term, yes, if we invest in it, but the political realities of a health minister who wants to, has to make political decisions. So, I mean, how do we deal with that?
Well, I think it's a challenge not just for the health minister, with respect. I think it's a challenge for the whole government here. It's a challenge as much for your finance minister as for your health minister. So back in the day when I was Chief Secretary to the Treasury in the UK, we had what was a relatively modest, what we call an invest to save budget, which was earmarked for precisely these sort of initiatives, not just in health, but in education, transport, etc., where cabinet colleagues could come and bid for money that was earmarked for precisely these purposes, things that they wouldn't be able to do otherwise, which would produce a return down the line. If you invest £1 here, you'll get a £3 return in future. And I do think that is something that governments, both in Northern Ireland and across the UK, should really be looking at, about whether it is possible to identify a pot of money that does unlock future investment, and not only unlock future investment, but unlock future savings.
We have a transformation fund, which is...
You do?
But yeah, it's like all of these things, it's just not big enough to do the things that we wanted to do.
Yeah, and that's a great example of that sort of idea. And I think the question is, can you extend that into other areas of public policy?
Okay. Danny, I'm going to bring you in.
Thank you, Chair. Thank you for that. I've already heard quite a bit of what I was going to ask about, but I think the NHS in itself is a victim of its own success in many ways, that we are now living a lot longer and surviving with a lot of comorbidities that, when a couple of decades ago we wouldn't be. But we are requiring a lot more care, and particularly in social care. In Northern Ireland we have a combined health and social care system. Do you think that model offers benefits as opposed to other ones where there is the split?
So I don't think there's any perfect health or social care system. There isn't. I mean, and there are upsides and downsides. Yours is notionally a more integrated system than ours is. The question really is it demonstrating improved outcomes? Because this is in the end the game that we should be in. It's not how a system is structured. It's not even how much you spend on it. The question is, are we getting improved outcomes? And over time, you're absolutely right. If you take a disease like cancer, for example, cancer used to be, and too often still is, a killer, but for very many people nowadays it's a chronic disease. It's something that people live with. And life expectancy is increasing. That's a great achievement, not just on the part of the National Health Service, but on the part of life sciences companies and so on, who've contributed to making that happen. So I think the question all of the time has got to be, are we getting the maximum bang per buck? For every pound spent, are we maximising clinical outcomes? And a lot of the debate, back to the chairman's questions, are, you take England, we spend about, £200 billion on the NHS now. which is the GDP, equivalent of the GDP of Portugal. Okay? And what we always focus on is how much money is that increasing by every year. So is it in getting an extra 5 billion quid, for example? Fine, that's a really important question. But what we should really be focusing on is what are we getting out of the 200 billion quid? And are we utilising that in such a way that maximising value and maximising outcomes? And I think that is the question that we've got to keep posing to ourselves, because otherwise the answer is always going to be we need more money. And sure, as we've been discussing, to do the transformation, you do need money to make that happen. But we can't just keep ladling in more cash unless we are, 1, improving productivity, 2, improving efficiency, and 3, getting better value and better outcomes. And those have got to be the sort of acid tests, if you like.
No problem. And thank you. And certainly it should always be about outcomes, and we need to be very clear about that. Many of my constituents, and probably across Northern Ireland, well, I know across Northern Ireland, many people are on our healthcare waiting lists for operations for years, 5, 6, 7 years for orthopaedic operations like hips and knees and things like that. What do you see as a strategy? What would you suggest as a way to try and clear the backlog and get to the teeth of it as soon as possible?
Well, we've been here before, so it was not dissimilar when I was doing the health job 25 years ago. Very long waiting, and it almost become a sort of question of cultural fatalism within the system. Hey, people wait a long time. No, that's just how it is. Well, it shouldn't just be how it is, frankly. It shouldn't be that people are having to wait in pain or distress or sometimes dying on a waiting list. And these things matter. Of course, they matter politically because it matters to the public, but they matter clinically as well. So how do you do it? Well, I think one of the success stories that's worth looking at is what happened in England in the 2000s. Where we got waiting down from, I think when the Labour government first came in 1997, people were waiting 18 months or more for a hospital operation, and by the end of it, people were waiting a maximum of 18 weeks, and on average it was around 6 or 7 weeks. So how was that achieved? Sure, you earmarked some resources for it to get waiting times down, but you also introduced reforms to make sure that, for example, patients had choice, so that they could go to a hospital that had shorter waiting times rather than having to wait in the local hospital that had longer waiting times. And if you made a choice to do that, then the hospital with the shorter waiting times that was performing better got more money. Got more money. So in other words, what you were introducing was incentives to improve. So there was an incentive on hospitals that were underperforming to perform at a higher level. And I guess the third thing is that we used a lot of evidence base, particularly from clinicians, to try to spread best practice. So this wasn't just a question of market incentives, if you like, being introduced, but it was also the aggregation of performance data, of really good practice, of getting clinicians who'd been successful in one part of the country to take that learning to a different part of the country. Because although we talk about it as one system, I mean, the truth is, to use an uncomfortable phrase, it's a mixed ability class. Some perform really well and some don't. There are enormous variations in performance. And the question is, how do you eradicate that? Because if you can get the performance of the best universalized, then you can make huge reductions in waiting times. So, and the final piece is, waiting lists are a product of two things, aren't they? They're a product of people who are already waiting, and they're a product of people who come onto the list. So it's a stock and a flow. And part of the answer in the 2000s was, how do we deal with the flow of people coming on? And that really was about investment in primary and community services to make sure that people were treated in the community rather than necessarily ending up on a waiting list in hospital. So those are some of the ingredients that certainly I've seen that have been successful in getting waiting times down.
And certainly that has worked previously in the past. Not everything is going to be mapped directly onto Northern Ireland and onto our situation, but certainly thank you. I know a lot of those directions were things that have been raised previously, so thank you for that.
Thank you.
Thank you very much. Very well, Mr. Millburn here today. Just a couple of questions there. You were talking there about the sort of the building blocks, and you said that change can take twice as long as you think it's going to take. What are the obstacles that create that extension of time and change? Is it resistance within the service, or is it a lack of political will, or is it money? What really are the obstacles?
I think it's a combination of all the above. I mean, the first obstacle is scale. I mean, the wonderful thing about the National Health Service is its scale. That's the blessing, it's also the curse. So it's a huge thing, you know, it's 10 to 11% of GDP, it's 1.6 million people. It's not a single organisation, it's a multiplicity of organisations. Here, you've got the great advantage, I think. You're almost at exactly, you've got almost the sweet spot of, you've got scale and you've got a place that is big enough, small enough rather, to get your arms wrapped around it. In England, it's a different thing. It's like 200 provider organisations. So trying to get everybody aligned is always quite a difficult thing. So there's a scale question. And in large organisations, whether it's in the public sector, private sector, it doesn't matter whether it's in health or anywhere else, the bigger you get, the more entrenched you become. It's just a fact of life. It's a cultural thing. You know, you get processes, you get systems. It's always been like this. This is how we do it around here. You know, you can hear all of that, those type of phrases. And so shifting that, and that is a behavioural thing. It's about how people behave, how systems perform, how processes work. That isn't straightforward. You know, you can think that, I used to think when I first became the health minister, you know, if I go and make a speech somewhere and sort of issue the words, utter the sentence, then it will happen. How wrong can you be? And you can even tell them, this is what I'm telling you, this is what I want you to do. But there's a limit. Sometimes there's a limit to politics. I know that's a difficult message to hear if you're a politician, but there is a limit to politics. And, you know, you've got to work out how you're going to influence both organisations, but also organisations are made up of individuals. And in the end, a lot of this is about clinical behaviour. How do you get clinicians to change their practice? And that's partially about transparency. You know, if it is a mixed ability class, then the public should know about it. And one of the things that we hold as health ministries, we've got huge amounts of data that we collect. And I think we should have, frankly, we should have a publish and be damned view about the data, which is that we should publish it. Because actually it doesn't belong to us. It belongs to the taxpayer, it belongs to the patient. Why shouldn't they see it? They should see what we see. Now the critical question is, at the moment that you do transparency and you've got insight, what can you do with it? Because the most frustrating thing in the world is to be given a bit of data and not being able to do anything with it. And which is why these other reforms about how do you empower me as an individual to have some locus of control and to be able to make some decisions that suit me. This is what starts to break down the barriers and the behavioural barriers to change. So we've got to give the patient and the citizen, in my view, not just more voice, but we've got to find a way of giving them more choice as well. So that's transparency, it's being able to choose, it's being able to have greater control over where you get treated, how you get treated, where you get treated. And this thing, so I'm flying back to England this evening and I'm checking my flight. And if I want to, I can cancel my flight. But I can't do that in the NHS. Wouldn't it be a wonderful thing if we could not only book an appointment, but I could change it? Wouldn't that be amazing? Why not? Because I do my banking online, I do my travel online. Why shouldn't I do my healthcare online? And that's now possible. So there's nothing that is stopping us from doing that right now. We're not waiting for some sort of technological revolution to happen. That has happened in every other sector of the economy, and it needs to happen in healthcare.
The other question I have, maybe it's an unfair question to ask you, because maybe it's clinicians that should be answering it, but we talk about the waiting lists, and we talk about, you know, we're working from the top down to reduce the waiting lists, but at the other end of the stream, there's more patients coming in onto the waiting list. And obviously one of the answers is to slow that down, and we appreciate that, and that's things that we're trying to do more preventative medicine and stuff. But is there a case for like a twin track approach that the elective surgery would be not just restricted to working from the top of the waiting list, the people who've been on it the longest, but also diverting part of the resource to dealing with patients who are coming on to the waiting list? Now, obviously, if it's life-threatening stuff, you couldn't do that, but is that something that...
I mean, it's a difficult area, and you're right. I mean, it's in the end, you know, I'd be cautious about politicians second-guessing clinicians, because you've got to make clinical decisions in the end. These got to be clinical decisions, and clearly the way currently that decisions about who gets treated first, that's usually a matter of a clinician deciding urgency and clinical priority. That, I think, is it should be. The second factor, I suppose, that is taken into account is how long you've waited. So if you've got, you know, 2 patients waiting for a hip operation and somebody's been waiting 18 months and somebody's been waiting 18 days, probably you're going to go with the person who's been waiting 18 months. So those have got to be the 2, I think, critical factors. There have been some interesting experiments in, and I think this is happening here if I'm not mistaken, to take into account maybe a third factor. Because one of the big challenges here and across the whole of the United Kingdom is this question of people being out of the labour market, out of work because they're ill. Huge levels of economic inactivity, almost higher here than anywhere else. And so that's an interesting question. So if you've got somebody who is potentially going to fall out of work, out of employment, because, I don't know, they need back surgery, should they be regarded as a priority in comparison to somebody who isn't? So I think that's a really open question that we've got to debate, and that might become one of the third factors that we need to take into account when we're deciding prioritisation on waiting lists. But I think, again, that's got to be informed by a clinical view and not just a public policy view.
Thank you. Thank you.
Or even to take that further, because it came up in our discussion about waiting lists, you know, do we need to prioritise healthcare workers who are on the waiting list, who, if they don't get seen, will have to leave work, and therefore that causes another problem. So I mean, that's another issue into that.
Yeah. No, and I think it is. It's part of that same sort of tension dilemma that we've got to solve, because, you know, again, this sort of question of economic inactivity is both a question of stock and of flow. And the really big problem, as you know, is that the stock's pretty steady, unfortunately, it's not moving, but the flow's increasing because more people are leaving work, and they're leaving it earlier, they're leaving it younger, often with mental health problems rather than physical health problems, and coming into economic inactivity and out of work.
I thought it was interesting, your usage of the phone and its potential. Since this meeting has started half an hour ago, I have literally got a message from my care. I was at an appointment yesterday, so I've got a letter, which I presume is a follow-up on that, and I can maybe not change appointments on this, but I get access to appointments, and so, I mean, we're a way ahead probably here in terms of encompassing my care, but there's an awful lot more potential that we can use in terms of saving resources.
No, absolutely. No, I think we're in the foothills of this.
Yeah. So, members, no other member has... Oh, go ahead, Orly, I wasn't sure.
Sorry, thank you, Philip. And thanks very much for your remarks so far. So, some of these questions might seem a bit repetitive, because they probably are, but it's just to tease out, when you were you identified the sort of 4 key things that make reform really difficult and hard. But it was basically a question around your assessment of where we're sitting here locally, maybe even in comparison to England. That what would you view as what our biggest challenge actually is? You know, is it a mixture of all of the above? The things that you mentioned around, you know, identifying what your problem is first and foremost, the responsibility and more control by the patient, all of that. But where we're at the minute, it almost feels like we're sort of stuck, and it's, you know, it's felt that way for a very long time. There was a lot of hope after Bengoa, and then it just sort of seems that we're not getting any further on. And it's just to get your opinion of your assessment as to why we are struggling the way we are to sort of move reform any further ahead.
Well, I mean, take what I'm about to say with a pinch of salt, because I'm not an expert on the Northern Ireland system. I'm really not. But you've got someone who is, in the form of Mike Farrer. Mm-hmm. Okay. So, and I think, I mean, what's been interesting, I've only been here for a few hours to speak at the conference, but my sense is in this conference that has just taken place, there's a real sort of galvanizing sense of energy. People are behind the reset plan, and they want to make it happen. And I think what has happened is that the penny is dropped, first of all, that the system isn't sustainable unless we make change. So you were asking, Alan, about whether there's cultural resistance and so on and so forth. Occasionally there might be, but I think nowadays mostly people working in the NHS realise we can't keep going on like this. We just can't. So we got to that point. That penny's dropped, and that's really important. The second sense that I have is that the reset plan is one that commands a lot of confidence, and it commands a lot of consensus within the system, so that's great. And the third point is that I think the three building blocks that you've got, which are the same as in England, they've got a really important fourth element to it, which is how do you move the patient from just being a passive recipient of care to being a partner in their own care, and I think that's a really welcome step. So I would say in terms of the overall, if you like, you know, the menu for reform, it seems to me to be on the right lines. Honestly, the really hard thing is not devising the menu. The really hard thing is executing it. Mm-hmm. Execution is the real challenge, and that is the challenge that, you know, the minister will have, that Mike Farrer as the permanent secretary will have, that people working within the system will have. So I think, you know, that is not going to be. It's not going to be straightforward because it isn't. But the really good thing, I think, here is that you've now got clear destination. You've got a clear plan in terms of what needs to be delivered and by when. Obviously, there are some bumps in the road to overcome. You've got this problem about the deficit that you face that is not straightforward and is obviously the subject of conversations, you know, between ministers within the government here. But in terms of overall direction, it seems to me to be the right direction.
Okay, thanks for that. And maybe just to bring it back to your other point around that we need to sort of look at how we're actually using the money that we have. So yes, we know we have a deficit, and that's the position that we're in. And until additional money's found, you know, the minister's in the position that he's in, the difficult position that he has to do his very best with the budget that he has. So, but just last week at the Health Committee, we had a briefing from officials around mental health in particular, and the officials were saying that there was a piece of research done from the Centre for Mental Health, I actually think is based in England. It does UK-wide sort of research for Britain and the North. So in its findings, it was saying that the cost of mental health here locally, that the cost to the economy was 10.5 billion per year. And we were having a discussion, you know, around if we know that this is the amount that it's costing us, you know, in terms of not dealing with poor mental health, bad mental health, and all the issues that come with that, that's the cost to our economy. So how do we try and, if we can invest earlier, to try and prevent some of that cost coming at a later stage? And it was just the point that you have made around then, which is crucial, and which we've been raising repeatedly with the health minister and his team. It's around how do we actually get to this point of shift left, and how do we get to the point of the care in the community and the preventative stuff, and exactly as you said, the incentive to keep people out of hospital. So it's how we, with the, and you probably won't be able to answer this question, because if you did, you'd be solving all our problems that we have. But with the position that we're in terms of the finances and the budget, how, is there even any helpful suggestions how you maybe move this further on in England? Because at the minute, GP services are on like 5.4%, I think, of the overall health budget. So they're making a really good case to say if we had, you know, even if that 5.4% was brought up to 8%, that would make a massive difference in terms of the preventative stuff and caring for people in the community. I mean, dentistry, community pharmacy, they're all under pressure and they're all doing great work. But particularly for that, I'm thinking about the general practice. First, how does, with Mike Nesbitt being in the difficult position he is in, how do we make any progress, not in 10 years' time, but in the immediate term, to even try and move that on any further?
I think there's a couple of things. I think, so maybe three things to think about. The first is that I think the word that you used is a really critical one, which is at the moment in the system, and this is true here and it's true across the UK as a whole, we have a treatment-first mindset. And what we've got to move to is a prevention-first mindset. Yeah. And so I know that that's a sort of easy and glib thing to say, but it's really important, because unless we have that mindset, then all the policy changes that will be necessary will not flow. So the starting point is that. I think the second thing to really think about is, are there means by which you can liberate sometimes modest amounts of money in order to make that left shift? But the critical thing is, so you can do some of that with modest amounts of money, with a few million here and a few million there, and they can have disproportionate impact, precisely in stopping the demand side and the flow coming into particularly hospitals. But the critical thing is, how do we use the massive money, not the marginal pound, but the mainstream pound? How do we use that? And that's about deciding what you want it used for. So I can speak for England more than Northern Ireland, okay? But for England at the moment, we use the mainstream pound mainly to incentivise more activity in hospitals in order to get waiting lists down. And of course, we've got to continue to do that for the reasons that I said earlier about waiting. But we need a different set of incentives which recognise and reward different things. And so I think the incentives over time have got to move to organisations being rewarded for keeping people healthy and out of hospital. And that means that we've got to have much more of an outcomes-based focus. We've got to be measuring outcomes and not just activity. And if we can do that shift over time with the mainstream pound as distinct from the marginal pound, the impact will be disproportionate. So that would be the second thing that I think is worth thinking about. And then the third and final thing is that the answer to most of this, in my view at least, is technology, not in a narrow sense of an NHS app or what is currently available here, but technology in its broadest sense. If we have got the ability to flex any expenditure, then one of the top priorities for investment has got to be innovative technology. Because through innovative technology, you're not only going to improve outcomes and do more prevention, but you're also going to get a better return for the taxpayer. So digitalisation, look, we're still, you know, despite what you and I both experience as patients, in comparison to many other walks of life, we're still living in an analogue world in the NHS, and we've got to get it into the digitalised world. And we know absolutely from every other sector of the economy that when you do that, it not only provides a benefit for the consumer, but it also provides an economic benefit. The higher the level of digitalisation, the higher the level of productivity gain. It's a very straightforward correlation. And one of the reasons that we have quite low economic growth is that we're under-digitalised and under-capitalised as a nation. So if there is marginal money, then over-investing in new technology, whether that be genomic science, some of the other omics, or indeed artificial intelligence, has got to become a priority for us.
That's very interesting. Thank you very much. Thank you.
So that was a very interesting conversation that we could have carried on. Unfortunately, we don't have time to carry on. But
I'll come back.
We do appreciate, first of all, I appreciate your attendance here at the conference and at this committee meeting. It's been very interesting. So thank you. Thank you for your time.
Thank you very much. Cheers. Thanks.
Okay, members, can I just ask a bit of interference at times, so if we keep our phones back from the mics and if we're, including myself, talk into the mics, that would be better. So we're moving on then to item number 2 on our agenda, which is an oral briefing from the Department on winter pressures planning. So can I refer members to papers at tab 2, page 7, and can I welcome the officials. Okay. Okay, so can I welcome Professor Sir Michael McBride, Chief Medical Officer, Ms. Maria McIlgorm, Chief Nursing Officer, Mr. Jim Wilkinson, Deputy Secretary, Healthcare and Policy Group, and Ms. Tracey McCaig, Chief Operating Officer within the SPPT. So you're all very welcome. Thank you for attending. I'm going to hand over to yourselves just to make some brief opening remarks, and then we're going to take questions.
Okay, thank you, Chair, for inviting us here today to discuss winter preparedness in the Department of Health in advance of the up-and-coming winter period. I'm joined today, as you mentioned, with Professor Sir Michael McBride, the Chief Medical Officer, Professor Maria McIlgorm, the Chief Nursing Officer, and Tracey McCaig, who is the Chief Operating Officer within the Department's Strategic Planning and Performance Group. I'm aware the committee had initially planned to hold this session, I think it was on the 18th of September, and that the Department had provided the committee with some briefing in advance of that in July, which provided some analysis and learning from our winter preparedness plans for 24-25, which I trust members found useful. As members will be aware, the Minister had published the Department's winter plan, setting out a range of measures being taken across the HSC to try and mitigate the up-and-coming difficult period when we know people get sicker for longer, meaning our already stretched system and committed professionals come under additional strain. I know that was published today, and I have no doubt members will be concerned that the plan has been published and that there's little time for scrutiny. What I can assure members is officials will here today to answer any immediate queries you might have, but we'll also be happy to return and members want a more detailed discussion on any particular issue or any particular aspect. As in previous years, one of the key functions of the plan is to communicate with wider society and members of the public the preparations that have been put in place across the health and social care system to deal with the additional pressures that winter can place on our already strained system, particularly in relation to urgent and emergency care. I would stress the winter preparedness plan is not the start of preparations, but rather wider communications of what those preparations have been and an opportunity to stress key important messages going into the winter period, not least to make the public aware of the importance of vaccinations and the alternative pathways that are available to meet their health needs. There have been two key drivers for the plan. The first is getting the biggest impact we can from the initiatives that we have put in place in previous years and targeting those that have been most effective, as learning from the past. And secondly, working collectively as a system to identify any additional actions that could support those who are most impacted by winter. This year's plan covers a range of themes and actions, including areas such as prevention, with an extensive vaccination programme covering influenza, COVID-19, RSV and shingles, working with pharmacy and general practice, covering in particular access and provision to medicines via community pharmacists, but including the Pharmacy First service, which aims to protect general practice through the provision of care for patients presenting with conditions such as uncomplicated UTI, sore throats and shingles. We're also working with GPs to increase capacity over the winter period by supporting additional sessions and consultations within practices and to deliver proactive care for those in nursing and residential care homes. Similarly, within our trusts, and in particular, learning from last year, we've been looking at a new approach to reducing ambulance handover delays, the establishment of a paediatrics winter planning team, particularly focused on the needs of children, and improvements in social care delivery to, amongst other things, improve system flow from hospital. Alongside that, we've been supporting each of our trusts that have been involved in extensive local planning and preparations, including working with their regional control centre to develop operational on-schedule care improvement plans, including their trusts will deal with pressures and surges in demand. Of course, in addition, this year, the Minister brought together senior leaders from across the health and social care system to explore the learning from last winter, looking at a whole system approach to what could be done and achieved both in advance of this winter and in the medium to longer term. This big discussion, whole system flow series, established 7 additional action plans, and I'll now defer to Maria and Michael to provide some further information on this process and the expected outcomes.
So thank you committee members for inviting us to talk about the big discussion. I'm conscious that my slides might have gone into the hands of the media yesterday, and so hopefully I can provide some context today into the background of this work. So if I just start with some background information. Last year, as you'll know from your briefing earlier, we had flu come earlier, and the services are already under pressure. We all know that. We know that we have constant pressures across health and social care, and that's exacerbated in the winter months. So part of the winter planning for this year was to bring people together from across the system. So we brought together, following discussions with the RCN and the Royal College of Emergency Medicine, who had highlighted these concerns to us, we brought together leaders from across the system in health and social care, frontline staff, including our medical teams, the community, voluntary sector, primary care, to look at and do a deep dive into what is actually driving the pressures for winter. And we know that actually from this data, if I bring you just to slide 2 in the session, in the slide that actually has this one, we actually got data that looked at across the system. So we looked at actually the flow into the system, how people move through the system, and back out the other end of the system. And that is really, really important, because it's not just about looking at one part of the system in terms of how we manage flow. So we brought teams together to look at that. There was 140 people came to the first session, and our sessions were oversubscribed. Prior to actually having our first session, we sent out a survey to all of the participants, asking them questions about their views of winter and what was important to them. And for the first session, we actually used that data to really do a deep dive into what was happening. What we found very quickly from the big discussion data is that actually it's the older people and older population. So it was really important that we focused our discussion around how and really look through the lens of older people, bringing people from across the system to do that. So as part of that, and I think we're all very familiar with what we identified as the red lines, and that's normalisation of ED as the first point of call for urgent care, long waits in ambulance for patients outside EDs, ED overcrowding, normalisation of corridor care, increased number of patients experiencing delays in treatment impacting on their outcomes, loss of dignity, poor patient experience, and moral injury for our staff. None of us want anybody to experience that, and none of our staff want that either. So it's really important that we look at this from a whole system demand and what is actually driving demands within our system. So our older people, if we bring you to slide in terms of our growing population, what we can see is in Northern Ireland there's a projected largest increase in pension population of 39.1%, and the second largest decrease in population of children, 19.8% over the next 25 years. That is significant for how we actually provide services. So doing services and providing services as we always have is not actually going to meet those demands. So we do need to do things differently. If I bring you to the next slide, and thank you to our GP colleagues and our tech digital colleagues for giving us this information. But you can see as people get older, they have increased comorbidity. And this is really important in how we respond. So the biggest demand for our services are older people, and that is older people with comorbidity. So we need to be able to respond to that, and that is what we did. We had 4 sessions in total, and we used real-life patient experiences to work through how we could actually take a better whole system approach to the care that we provide. Out of the big discussion came 7 projects. One is around the identification and risk stratification of frailty in the over 65s, and that is really, really important so that we can get upstream and actually take a better understanding and actually be very targeted at how we care for people with frailty. Supporting people to be well and cared for at home, and also enhanced clinical care in care homes, how we actually take that forward. Avoiding admission at the end of life care. We know through the stories that we use that many people are actually presenting to EDs and in our hospital beds at actually end of life care that could be provided in the community. The provision of appropriate, sensible care, so that actually when people come into the system, their care is appropriate and timely, and then we're not over testing people when it's unnecessary. Frail elderly pathway for ED attendees post-fall. That's another area that's been looked at. And if any of you were at the session earlier on today, when they looked at the data for that, the 3 presenting areas are fall, respiratory and cardiology, and work is already progressing to look at that and how we can do things differently. Advanced care planning was also one of the key areas, and how we manage elderly people with fractured neck and femur pathways improvement group. And that is really important for several reasons. If we actually don't operate within the 48 hours or is near to, the outcomes and the consequences can be quite significant. So this is a really area that we need to improve, and particularly for older people. So our focus of the big discussion, whilst it does link with winter planning, it's about managing whole system demand and how we do that differently. And it's about getting the system to work more effectively together. And to do that, everybody in the system needs to understand their part of the system and the interconnectivity between the system. So there's many of the team actually sitting here in the audience today who actually took forward this work. I was really impressed by people coming together around a problem, doing a deep dive into the problem, and a consensus that we have to do things differently if we are going to respond to the population health needs in Northern Ireland, and particularly the greatest demand, which is that of our older people and people with frailty. So that was the big discussion on a quite short notice. Happy to take questions.
Just 2 very quick points, and thank you to Jim and to Maria. Just to emphasise that changing demographic of the population. At present, 1 in 6 of the population are over 65 years of age. That is rapidly growing. We have the most rapidly ageing population in the United Kingdom. And between 2016 and if we look forward, project forward to 2041, there will be more, the number of people in our society over the age of 85 will have more than doubled. And that's why this work is so critically important. And as Maria said, this was not a replacement for, substitute for the winter planning and preparation. And as we outlined in the paper to you on the 2nd of July, this was an adjunct to and complementary of. In a similar way, just putting Maria's comment into context as well, whilst we're here to talk about winter planning and preparedness and the high-level representation of that in the winter plan, this is also very much related to the elective care framework, all the work that we've been doing around unscheduled care, all the work that we've also been doing around primary care, and importantly as well, as I know members have flagged and have been briefed on previously, the work around social care reform. So this is an interconnected system, and I think it's important that on our reflections today, you may hear us refer to different pieces of work, not necessarily related to winter planning and preparation. Thank you.
Okay, thank you. So I'm going to start. Obviously, this winter preparedness plan is vitally important for our healthcare sector in the months ahead. And I don't want today's meeting to be distracted from the important role it has in the detail in it. Unfortunately, I have to start off with expressing my disappointment about the fact that this committee only received it via a link. I mean, I actually was alerted to the fact that it was published from the Department of Health's Twitter feed, so the committee didn't even get it in advance of that, and that was only an hour before the meeting. So, I mean, I certainly haven't had the chance to fully engage with that, which is very, very disappointing. So, I think that, I mean, that may be a cause for distraction, and I know there was there was a bit of media attention yesterday about engagement as well. So, I mean, there certainly could have been much better PR positivity around this vitally important thing that is taken away from the detail of it. I think it's important to set that on record, that certainly this committee and the members on it are extremely disappointed that we're discussing this very important thing at 2:30 and we received it fortuitously at 1:30, and it absolutely isn't giving us the respect that we deserve in terms of scrutinising the plan. So I think that's important to say that. Secondly, just in terms of some of the stuff that came out of the media yesterday. So in the plan, there is obviously it crosses sectors: primary care, secondary care, social care. I think it is important again to put on record, certainly from what I have heard and engagement that I have had, that there is going to be an awful lot of disappointment that there are asks within this plan of GPs, of pharmacies, of other sectors within our healthcare, and they feel that they haven't been engaged with to the full extent in terms of the detail, and they'll be asked to do things, which may have implications for resource and the work that they're doing. So I think it's important to do that. I don't know if anybody wants to respond to that.
I mean, I'll answer a couple of those questions, and I'll bring in some colleagues on some of the detail. First of all, as I said, I'm disappointed we couldn't share the plan earlier. The plan publication wasn't linked to the committee meeting. It was published when it was ready. And we will be happy to talk generally today and come back on any more specifics. But the main point I think it's important to stress is the winter plan is not the starting pistol for activity to take place. It's not the starting pistol to ask GPs or pharmacists to do anything more. What it is a point in time in the preparations that have been taking place when we can tell the public, here's what we're doing, here's what we're going to do, and here's what we can expect. So I think on the specific points in terms of primary care and pharmacists, I'll ask Tracey to say a bit, but we do know that we engage our GPs early on to look at what is it additional we can invest in winter time that will help, and they tell us usually sessions and also working with care homes. We also engage clinically with pharmacists, and indeed pharmacists are really keen that they can play a major role in terms of anticipatory care. I should also maybe say the winter plan is in the context of an urgent and emergency care strategy, which is a strategy that runs for 5 years. It was consulted upon in 2022, very extensive consultation, ended up with 3 big things. One was implement a series of things called No More Silos, all of which feature here, urgent care centres, emergent pathways. The second was carry out extensive comparison with the Getting It Right First Time team in England to tell us, is our emergency care as good as, and can we learn from it? And the third was to really promote hospital at home. So that has continued to set our strategic direction. And the Urgent and Emergency Care Board, which oversees its implementation, has representatives from general practice, from pharmacy, from nursing, and from the Royal Emergency Colleges. So I can understand a lot of the conversation yesterday was about lack of engagement, and there was some concern how that might be through, and I think it also got conflated with some other issues regarding where we are in terms of pressures in the system. But with regards to plans and regard to the activities in this, it would be really remiss not to acknowledge the hard work done by pharmacists, GPs, and all clinicians in helping shape these actions. But I'll hand over to Tracey for some detail.
Yeah, I think maybe just to focus in on probably GPs and the pharmacist piece of that, and I'll bring you into some of the detail. So within, when we work with our GP colleagues for, am I not near? You hear me? So when we work with our GP colleagues in enhanced services, and that's how we add to the base contract, there is a very formalised mechanism for how we do that within my team. So we will have an internal group, and we will have GP medical advisors employed by ourselves first stage. It goes out to the NIGPC, a representative body. They will get an opportunity to consider how we've written up the enhanced service, get a chance to feedback and give us our comments. That will come back in. We will reflect on those comments. Changes may be made, changes may not be made, but that's the process. So there is engagement on the additionality, and what we're doing for the winter, we have invested through our winter plan significant money to go in to buy additional sessions. Now, that we have to set in context to say that those additional sessions, we need our GP community to be with us. They believe through this that they can help us with the additional sessions through that winter plan to help manage. That's not unlike what we have done in other years. They've also worked with significant, we think there'll be something like 10,000 medical care plans for our care home sector as well. So those things are in, they've been communicated with through that route, which is our normal route for doing so. For our community pharmacy team, I have to say they've been really great in working with us on a number of enhancements. Our UTI service, sore throat service, all of those that were kind of in from last year, and we continue, and I personally have had a lot of engagement with senior representatives of community pharmacy NI, but where they have been really helpful tying into Maria's one of the projects on the big discussion is around the palliative care space, and that's been different. So what we have done is to work with a lot of community pharmacy TNI to buy additional lock boxes so that we can have access to drugs for people in the last 30 days of life. They have worked really closely with us and really proactively and have been engaged in one of the projects that we're in. So I think there has been engagement, and I think it was disappointing, and I think disappointing for those that have engaged with us that that's been a strand that's come out this week. It certainly wouldn't be the reflection that I have seen of the commitment from both of those areas. Not least our C&V sector, our community and voluntary sector colleagues have been exceptionally supportive to us in the middle of this. We'll have meetings again with our independent sector, care home and home care providers. There's another session coming up, and there's been a number of roundtables with our trust colleagues and independent sector colleagues. So there's been quite a lot of engagement, but have we sat down and said we're going to engage on this whole winter plan in the way that you're asking that question? No, but on all of the component parts, which is right for an operational plan.
Okay, and I should have said at the start before I came in, you know, all of us members will have a lot to ask, so I'm going to try and keep my questions succinct. I won't interrupt anybody, or won't interject, so we'll all get questions, keep them succinct. But in terms of winter, I mean, Jim, you said what's happening in winter is part of an ongoing systems pressures. So, I mean, winter doesn't come upon us by surprise every year. We know it's going to happen every year. We know the pressures. So, I mean, what's different in this plan than last year's plan? And how? And the other thing is, what impact do you see having that difference having, and how do you measure success?
Yeah, I mean, again, I'm going to bring Tracey in as my operational colleague, but from the policy perspective, you're right. I mean, winter pressures are a manifestation of pressures in the system, and therefore planning for pressures goes on each year. Each year it is an iterative process. We learn from what did we do last year? Did it have the impact we didn't? We expected. Did it not? What could we do differently? How do we enhance? And those conversations begin, I was going to say as soon as the winter period ends, but it's not. It stretches into February. We begin those in March. And Tracey and his team go out with trust teams, and we work out what is it we could do better. I have to say there's no winter plan as a panacea for addressing the pressures in the system across. We're not going to solve the pressures in the health system with a winter plan, but what we are going to do is try and do what we can to mitigate it. And there is really challenging operating environment, and we can't ignore that. But how we measure success, for example, one of the big challenges last year was a big spike in conveyancing time for ambulances because significant numbers of ambulances were outside ED departments. There wasn't a spike in ED attendances, there was a spike in ED flow. So one of the things that we did this year, and Tracey's team have led on this, but with the Trust and with NIAS, was to say, right, last year we said we're going to reduce that in ambulance times. What can we do more this year? Because we want to measure the impact. We want to see that as a reduced wait time, but more importantly, greater ambulance availability for those Cat 1, Cat 2 calls. So I'll let Tracey maybe give a bit of a detail about that one in particular, just as an example.
And I think it was Jim or Michael maybe mentioned earlier, each of these elements can't be seen in isolation. So, for example, in the neck of femur project, in the big discussion, that's very closely tied to our elective care framework and the developments we're doing there, as well as all of the other work. So we've had some early success even in that, which is really important to tie into our ambulance out of areas as well. So it's the interconnectivity. On the ambulance piece, for example, we've had, and I think I mentioned that maybe when I was at committee 2 weeks ago, we have set and agreed targets across the system where the handovers and the wait times, which will release ambulances a lot more quickly than to improve on the times to respond. So at this point, we've had the first month of that agreement, which was to be no more than 4 hours. Now that seems a very long time, but there's a lot that hand over earlier. And we've had, it's some really good success in some other areas where there needs to be improvement, which we're focusing in on with those trusts with support of Getting It Right First Time and other colleagues. So we've had 4 hospital sites that have been under 1% of that the whole of the month. And indeed, Daisy Hill has been an exemplar and had just had a visit from Getting It Right First Time, and were commended for the work that they were doing in that space. So I think really important to mention when really good work has been done.
So you just explain that the 4 hospitals are under 1%?
So under 1%. So what we'd said, no more than 4. So there's 1% variance to hitting that 4 consistently, and below the 4 hours.
Okay.
So, for those that find it a little bit more challenging, we're then focusing in to see what do we need to do, because the minute we end at September, we move to a 3-hour backstop, and we have to be able to push into that really hard. So progress made, some challenges, but we're moving into that. So that's one measure of success, but we're already measuring that now. We won't be waiting till, you know, after a Christmas period to start to look at that. So that's one thing. Okay. If I might, I suppose what you will also have to supplement the departmental summation of all of the plans, or the operational summaries that you will have from each of the health trusts, including our ambulance trust. And you'll see a little bit of that summary as to how they're working through, including how they look after their staff through a really peak period of pressure. And lots of different elements within that. For example, an increased development. We repurpose some money, and what we have got is acute care at home increases. So we have established it in Northern Trust. They didn't have it before. So that should make an impact at the early stages of at least 10 individuals a day being managed, and it will tier up. We have about 40 patients a day extra coming through South Eastern Trust, and it will tier up. So what we've got across all of that, all those little bits of development we've driven in, opening up our same-day emergency care to 7 days in certain places where we have capacity to do so. All of those elements will be measured separately, but we put the money where we A, have capacity to do so, B, where we think it will make the biggest difference. And lots of those elements of the new plan are in from end of October and into November, and are really tearing into that period. And that's a recurrent investment. So as well as driving efficiency from what we already have on the ground, then there'll be additionality coming on through this period.
So you mentioned same-day emergency care. Just walk me through that. How does that work, and who goes there?
So there'd be different routes that would mean that you could end up in same-day emergency care. So those might be individuals who come to the ED. There are GP direct access elements, and there are also NIAS elements. So you could be a candidate for, but you may come through the front of the ED, and instead, traditionally, you would have ended up in a bed, probably in an acute medical bed, and you would have had your tests and everything there, and you would have stayed and stayed overnight, at least one night, maybe more. And now what you'll do is you transfer in to your SDEC services, as we call them, and you might have within that same bay, sometimes it's a big chair or whatever way the space works out, it could be 1.5 to 2 times. So 1.5 to 2 times usage of that in a day, rather than one person taking up one bed for a night. So it's a really efficient model. It gets patients back home to their families with the treatment that they need in a much timelier way, and I think it's been really successful, particularly in things like respiratory, where you're able to go in, be stabilised, and return home. So Michael might be...
just in other areas like cardiology, for instance, again, individuals, for instance, with congestive heart failure, there's a number of other sort of very innovative models, for instance, around monitoring and remote monitoring, a very innovative model within the South Eastern Trust, again, which is probably not reflected in the detail of their plan around managing people with congestive heart failure remotely having been assessed. So again, that basically ensures that individuals can have the care that they need, have the assessment that informs that care, and then return to their own home, and then be managed out of hospital and maintained out of hospital. That's what's best for them, and it actually then reduces some of the pressures within the hospital. Just the other thing to add, I know Maria wants to come in as well, a very quick example, and the other colleagues will be best placed to talk about adult social care, but there's been a huge amount of work this winter as well. I know Dan has had her hand up for some time, and I know it's something which you've spoken about before and have engaged with Southern Trust around social care. Social care colleagues have put in a tremendous amount of work in terms of rapid review and assessment in terms of individuals who perhaps are having and requiring home care, in terms of maintaining them at home rather than the breakdown of home care packages, which often is the case. There's been a significant amount of work around review of home care packages, for instance, and then the redirection of something like 7,453 hours, which has then been reallocated to individuals who are needing either increased packages of home care to maintain them in their own home, and also significant work. And again, this is an issue which has been problematic for a number of years, protecting home care packages for individuals who are admitted to hospital. So now there's agreement across the region that when individuals are admitted to hospital who are in receipt of home care through social care colleagues, that will be protected for 14 days. So again, that should stop the sort of bottlenecks of individuals being medically fit to go home, but actually their home care package is no longer available to them. So significant work in that space as well.
So I mean, that protection will be very useful, because I know from a consistency point of view, it's a major thing. I mean, I was looking through the minutes of the meeting in January when the Minister come in the midst of last year's crisis, and he had talked about social care and said that, you know, he would deal with the workforce issue and pay. I mean, the pay issue hasn't been dealt with. Whether there's an announcement today that helps that or not, I'm not sure, but certainly there's been no living wage applied to social care staff, which is disappointing at this stage. So you're saying that there's 7,000 redirects?
Yes.
Can I ask, because it's also, there's always a major issue.
Hours per week, yeah.
So, I mean, flow through the system in the winter is crucial, that it flows smoothly, and obviously one of the stopping blocks is care packages and getting people out of hospital. So that 7,000 hours is useful, but is that geographically spread? Because there's always an issue. There's a difference between urban and rural in particular.
There is, and I know, I mean, so there's another element which obviously Tracey's probably better placed to comment on, is the block contracts which are being looked at, because you're right, there are real pressures in rural areas in terms of the availability of that home care, but Tracey, I'll hand over for the detail to you.
So I think it's to set in context as well how many hours of home care that we actually provide. So we provide something 300,000 hours of home care a week to about 22,000 people on average. So it's a significant resource, and it's a significant workforce, both within our trusts and within our independent sector providers. There is unmet need, and that unmet need is not spread evenly geographically, and there are challenges in rural areas. Those challenges, trusts are looking at how they work with providers to do different things, and there's been a number of tests this year to try and generate more need. But it comes down to availability of workforce and whether it's an efficient run for a provider to take on at the point in time where it's very disparate. So there's lots of different ways we're looking at that with our providers, but it does come down quite often, unfortunately, to workforce and being able to do that. The level of unmet need, you know, isn't static either. So if we were able to find workers today for all of those places, would change next week and again, and the level of cost that we would have to provide is really outside our gift at this point in time. So there's financial issues for us, but there's also a workforce, and the growth in the demographics that Michael referred to earlier. We're chasing it all the time. It's really, really difficult to get that, which is why the other parts of this system working well, get you in hospital fast, like the neck femur, get you back out, get you through your reablement fast, means that you shouldn't need as much social care. So we're looking at those things, as well as how we provide social care and how we provide care faster and quicker in those areas to stop you needing as much. So all of that has to be.
I suppose what is becoming clear to the committee is that there is no single big thing to deal with the preparedness. What we try and make is gains everywhere we can, and the cumulative effect of those gains have an impact. So in social care, as Tracey described it, there is a gain to be made at the strategic level, looking at how we work with providers to make it an attractive employment opportunity and promote it. There is the role of pay, and that's part of those wider turbulences we have to look at. And then there is the marginal gains in even administration activities within a hospital at discharge, looking at reviewing packages, seeing if you can get hours somewhere. So it's a series of events to try and make a change. But what's become clear through all of these, there's no real single activity that we can do within the means we have available, because that's all a part of our operating environment.
And perhaps just even to mention Care Home Live, and if you've had the social care colleagues with you, you might have heard about that. All of our trusts now have Care Home Live in place. And for an example, just sitting in South Eastern Trust alone, from the 1st of April to the 30th of September, 2,116 hours per week were released and recycled. So that, along with all of the other things we're doing, is how we're trying to meet demand, because we don't have the financial resources or the workforce resources to be able to do otherwise. So we have to make the best use of what we have and make sure it's as efficient as possible. And there's been real great strides by our trust colleagues and working with our independent sector colleagues to try and make that happen, and that early review teams as well in all trusts and pushing through this. So that's where those gains are coming in, and we expect as that moves on that we'll see that really come into its own over the course of next year. Okay. We don't know whether we've got whether it's an untapped, have we found the magic number and that's as much as we can recycle, or whether we can go a little bit further. That's what we'll keep testing. But for the winter, it's all in, it's already happening and moving through the system as efficiently as we can make it.
So I have a couple of, Maria, do you want to come on that?
Yeah, I just wanted to come in really around that demand. So we know in terms of the conveyancing from the work that we've done through the big discussion that the biggest number of calls to the ambulance services are actually older people. We know that the delays at the back of ambulances are older people. We know that older people are in our corridors. We have to get upstream with this. One of the projects which came out, and I think it's really important for me to say that when we brought all of these people together for the big discussion, they came up with these 7 projects. It hasn't been something that we've said it's a good idea, and it was through a deep dive, and it was really through understanding what is the problem and the contributory factors that we're trying to fix. So one of the projects which has come up is around identifying frailty within our system here in Northern Ireland. Now, we have the capacity to do that through our systems. We haven't done that before, and work is ongoing, and there's a team looking at that. They've got 3 streams of that, but frailty is a big aspect of the care that we provide. This year, we've already focused targeted training for staff, particularly our community staff, our GPs. We hadn't done that this time last year. That's really important in both identifying and how we actually respond to people with frailty. But actually, when we index people and actually know, we can then get even further upstream with this in terms of how we targeted support for older people with frailty going forward. And frailty can be stopped, and it's one of the biggest costs to the health service. In the UK, it's been estimated at about 58 million. That's a lot of money a year. So we need to support that, but also for older people, we need to make sure we're doing the right thing. And can I draw your attention to this, because I didn't mention it when I talked, but this is PCC's survey that we commissioned them to do as part of the big discussion. We've not done this in Northern Ireland before. We've not done it anywhere before, to be quite honest with you. So thank you to PCC for doing this. But what they did, they've got a baseline assessment of what the people in Northern Ireland think of winter, how they use emergency services, what they see as their pathways into services. And there is learning for this winter. So how we communicate more effectively the pathways out there. Now, there is a variation, and the good thing about bringing this together, and Michael may want to speak about this, is actually reducing variation in both how people access services, but also when they're going through services is really important, in how we use our resources more efficiently, but also for better outcomes for people. So that's, I don't know, Michael, whether you want to...
Yeah, there is, again, very briefly, I'm very conscious Dan has had her hand up for some time, Chair. So one of the areas that we presented on at NICON conference yesterday was the work that we've been doing as part of the big discussion to basically make sure that care that we are providing is absolutely appropriate for the individual in their particular circumstances and consistent with what their wishes are. And, you know, this is something that has been around for a very, very long time in other parts of the world around value-based healthcare. So it's about what people value, what's important to them. It should always form the basis of decision-making. Because obviously any intervention, whether it's a diagnostic test or a treatment, has risks and benefits, and it's important that individuals have the ability to make informed choices and decisions about that. That was manifested and launched in 2016 in Wales as Prudent Healthcare, and in Scotland, colleagues will be familiar with the realistic medicine approach. We are now, and just taking forward this year, as part of the big discussion, a significant piece of work around our equivalent here in Northern Ireland. That has been a very engaging conversation, working with, and again, I've had a conversation yesterday with the Older People's Commissioner. We will have been involved in prototype projects across 3 of our trusts. We're about to get one of the 4th trust involved, and we are working with our regional clinical networks, looking at, as Maria said, reducing the variation in both access to care and the care that's provided across cardiology, across stroke services, again across respiratory, working with the respiratory framework. So very much clinically led, informed by the evidence, but actually seeking to reduce what we call unwarranted variation, where perhaps there's inconsistent application of clinical guidance or evidence, but also ensuring that it's okay to have warranted variation where an individual may say, this is not a priority for me, or this is an investigation or a treatment that I do not prioritise for me personally. So that's a very significant piece of work, and it's a very new piece of work. As a chair, you asked what we were doing new or differently, and I think also it will make for more efficient, effective care, but more patient-centred, person-centred care and shared decision-making.
Okay. Very quick question. I'm over 50. I mean, when did we, sorry, that's not news, but I'm leading to a question. Vaccinations, so when is there going to be a public campaign about vaccinations? When?
Well, I'm happy to answer that, Chair. I mean, the vaccinations have already commenced. As you know, the influenza vaccination programme started back in September, the COVID vaccination September, and the COVID vaccination programme on the 6th of October. I mean, obviously there has been significant engagement on those programmes. Because of financial constraints, we've not had the same budget that we would normally have for public information campaigns, but again, those vaccination programs are underway. And I would just appeal to members and everyone else attending today's event that it's an important message to get out to those individuals who are eligible to vaccines, that vaccines are safe, they are effective, they are the most effective way of primary prevention. They keep old people and those at risk, those who are immunosuppressed, out of hospital each winter. They prevent severe disease and death, and the vaccination programme in children not only protects children, but also reduces the risk of community transmission and the exposure of older adults to influenza. COVID vaccination programme is different this year as COVID becomes more of an endemic disease, and it's very much targeted to the over 75s, those in care homes, and other vulnerable individuals. So it's a very much more targeted and restrictive programme, and it's different from last year with COVID, where we're not offering the COVID-19 vaccine to healthcare workers.
Okay, so it's up to me to go with the vaccination. Is that's
the only other thing? Well, I mean, again, there are different arrangements in general practices, and it's important that some GP practices will run, big clinics. Some will individually call individuals forward. Some will use text. So whatever the arrangement are in your normal practice, those arrangements will pertain. The other new thing, obviously, which we introduced, and Maria's thankfully just reminded me, was the RSV vaccine, which again is really, really important in terms of protecting very young babies. And obviously that's a programme that's offered during our antenatal clinics and also is offered to the over 75, because RSV can be quite debilitating for particularly young children, and certainly once we get to over the age of 75 years of age.
I would prefer to say that all those who are eligible have already started the process of starting to contact anyone who's eligible, has started with GPs. So it may be, Chair, 50's not that old, and maybe you're not eligible.
Okay, so very last question for me, and I haven't got the detail of it. In terms of the sensible care framework within it, sensible, I'm not sure is the right word, but how does that differ for what's currently been happening?
That's what I've just covered in terms of actually reducing unwarranted variation in care and actually tailoring care to an individual. So that's the mnemonic, as you would say, is sort of what we will be doing is engaging with. I mean, you raise a very valid point. I think it's very important that we have something which we own in Northern Ireland, that the public owns and understands in Northern Ireland, and professionals providing care own and understand. We have called it sensible care until such times as we engage with the public as what should we describe this as? And I think that will be through a process of engagement with the public. We'll be using the good offices of the Patient-Client Council, as Maria referred to earlier, engaging with professional colleagues. So we're at the start of a journey on terms of how we take forward that policy framework and everything that underpins it.
Okay, thank you. Danny?
Thank you, Chair. I, like Philip, was shocked just to receive this just in a very short time period before the actual meeting. Haven't had time to digest the whole plan or go through it. What I really wanted to do was compare it to your 2 previous plans. But when I got this document earlier on in the week, the 10 pages regarding the big discussion, I was very shocked by what we'd actually got. It seemed very light on detail. There didn't seem to be anything in it. The red lines page, and I think you'd listed them earlier, Maria, the red lines: normalisation of ED as first point of urgent call, long waits of ambulances for patients outside EDs, ED overcrowding, normalisation of corridor care, increased numbers of patients experience delays in treatment, impacting their outcomes, and loss of dignity, poor patient experience, and moral injury of staff. These are all happening at the minute. They've been happening constantly.
Yes.
So the idea that these are red lines, that red lines shouldn't be crossed, these are crossed on a daily basis normally. So going into the winter, that adds more concern, higher pressures on an already pressurised system. We've seen ambulance waits all summer. We've seen corridor beds all summer. We've seen people unable to access care all summer. So the idea that we're now approaching an elevated pressure time period is very, very concerning for people. Reading up on the last winter preparedness plan, so I pulled the last 2. 23-24 was produced on the 4th of October, so that was a bit earlier. Last year's was produced on the 6th of November, and I wanted to know, learning from last year's plan, there doesn't seem to be anything in this year's plan that I've seen so far. Based on learning from it, what did you learn from the implementation of last year's plan, and how did that go?
And I will let Tracey talk about it, but one of the papers that was provided to the committee, but it was in advance of when we were supposed to have the meeting, was specifically to ask that question: what have you learnt from last year? And we've touched on some of it.
We should have got that?
Yes, that was provided on 2nd of July.
2nd July.
Oh, previous, right.
In advance of the meeting that was postponed. So this is the meeting that
okay.
Right. So it was the paper that was our analysis of what had happened in 23-24. And it did say that some of the activity we'd taken hadn't had the impact we wanted, particularly around ambulance handovers. It also reflected on that there was some delays in terms of social care packages, and they need to look at it. But it also highlighted that sheer numbers, in terms of numbers of attendees, were not any higher in winter than they were in previous months. So it reflected the fact you've got ongoing pressures, but certain things happen in winter as well. It also highlighted spikes, particularly in October. I think it was October and January. And it was those findings which were available in March that we used to engage with trusts to discuss what is it we should do this year. It's those that Tracey's team had manifested as a new investment in and engagement on those ambulance turnarounds and that reducing timeline. It's those that have been invested in doing all we can in the social care space to improve administratively how we administer discharge and assessment of packages, doing how we recycle packages, and also looking what we can do to invest in where we know there are challenges, particularly around rural areas where it becomes a major area, and that's some of the block booking. So that's how those manifest straight in. They are and will be counted now immediately to inform what has worked and what hasn't worked in the winter plan. And I think maybe there is a good lesson learned here in terms of communications, which is the point you've made. And I'll stress it again, we probably should articulate more clearly that the winter planning process has commenced. Here's our planning assumptions document, which actually we deal with trusts on, and that's where they hear ambulance turnovers, resus beds. We should maybe say, this has happened now in February. We then should say, here's our learning, and we will publish the plan at a point in time, which you've highlighted. We can say what we want. We always land around October. But in many ways, the plan is saying to the public, this is what we're going to do. This is what we've done. This is what you can expect, and here's some of the challenges, and here's how you can help. So there is a timeliness about it that we do have to think about. Yeah. But there's I would agree, there's something about clear communications that we need to be clear to everybody, that there's a planning process, an implementation process, and an advisory and a sharing of what can be expected. But I mean, again, I would say all our plans try to make the best improvements we can. We're becoming more focused on what are the incremental gains that we can make that collectively will make a difference, and that's why some of the things reappear. You'll even said you will see one of the areas in the plan say we've also gone to the other angle and said, well, how do we deal with surges? because those are what happen. What would we do with surges? And some of those involve actually consciously saying and being clear, when something surges, we will have to increase beds, and increase beds we will have to escalate the number of beds we have, and some of that may well mean being clear that this is a suboptimal level of beds that we're trying to cover, but we're doing it for a reason, so people know and can be clear what to expect. So it is about that process of learning, and I think we should, and I think it's been clear, we need to articulate that more clearly.
And Danny, can I just come in on the back of that, is that actually you're absolutely right, but the people that are in our beds are older, frailer people. They're a longer length of stay when they come in, and some of the falls work that we've done through this discussion, and there's people here that can talk to you separately about that, has actually really identified that people are coming in with falls that probably don't need to be admitted to hospital, but when they are admitted to hospital, their length of stay becomes long. We do lots of interventions for them that probably aren't necessary, and actually that's a delay in the system. So we need to really get in and around this, because it's about every single aspect of this, which is why we took a whole system approach. So you are right, and whenever you have those pressures within the system, pre-winter, then the winter pressures totally exacerbate that. So we need to get upstream in this, and that's why the focus has been predominantly on this, on older people, and bringing the whole team around it.
Chair, if I might just very briefly not answer Danny's point, because you flagged a really important issue. I think it would have been much more helpful to the committee had we come along and, as what had been planned, to meet with you in July to walk through the paper in terms of the learning from last winter, and to outline the plans for this winter and the approach that we were taking, and that would have involved you asking us questions and answering those in a timely way, and then to come back again with the plan. Unfortunately, obviously, there's lots of, you're trying to cram a lot into a very busy schedule. I think a key learning point, as Jim has suggested, is that at an early point in time following this winter, I think an opportunity to come and brief the committee would be actually very helpful in terms of what worked, what didn't work, what we're learning from that, an update from the work around big discussion, and then the approach that we're taking to this winter's plan, prior to actually any publication of that. Now, of course, there may be a different and more effective way of doing this, and the Minister may determine that there are better ways of doing that. But again, just to reiterate Jim's earlier point, we'd be very happy to engage either subsequent to this meeting or next year in a very different way and much, much earlier, if that would be helpful.
Thank you for that. You'll be aware that there has been a bit of talk just about lack of engagement, particularly with GPs, and you'll have heard over the airwaves over the last few days. They felt that maybe there wasn't enough engagement. I think there was 4 GPs at the first meeting out of 150 people.
So I can respond to that, yeah. Danny. So we did write very early on in February to the GP, Northern Ireland GP Committee, to ask for nominations for GPs. We didn't get a lot of nominations back. Some of them weren't able to attend, who were invited, but we did have consistent presence of GPs there. On the subgroups of all of these groups, there is GP engagement, good GP engagement, and GP engagement is really important in that. So it was a bit disappointing, I have to say, to me, to hear some of the what was being said yesterday, actually, as well. So, and also, I think we need to be very mindful of the people who have actually stepped forward from busy day jobs to take this work forward as well, in a view that they really want to make a difference for the people who use our services. So, and the impact that may have had on them too.
There's also a concerning public part to this, because if I'm 85 years of age or I have an underlying health condition, I want to know that the health service, from community services, primary care services, acute services, and everything back across those transitions of care is and has been planning and preparing for this winter, which we do every year, as you quite rightly said. We have been doing that, and I just want to reassure the public that we've been doing that. And what I want the public to hear is that we will be working and have been working to ensure that where they need care and they need access to care, we will do and will continue to work as frontline professionals do on a day and daily basis, as you've said, Danny, to ensure that's available within the resources that we have and as timely ways we possibly can.
Thank you. And just staying with the GPs, just had a quick read through the plan and compared to last year's, there doesn't appear to be any detail on GP funding this year, any extra funds that are going to GPs. Now, there had been in previous years. Is there a particular figure that you can give for that?
I'll ask Pastor Tracy, and there is. What it is, it's additional funding made available in winter to support those two initiatives that we referred to, additional sessions and engagement of care home.
Is there a figure in the
There
report?
is, and if I could find it, £2.5 million has been made available to support the practices in that increased capacity, and that's to help support medical care plans and the additional about 8,000 sessions we reckon that will provide over those peak winter periods.
Is that on, Tracy? Sorry.
2.5 million in total.
What page? Sorry.
Oh, sorry, it's not. It's in my. I don't think it's on a particular page.
I don't think it's
it
on
may
that,
not. May not be in that. I'm sorry. I'm reading.
So it may
it
not be. May not be in the report, or
it may not be.
It may not be quoted in that way, but I can tell you it's 2.5 million.
It is 2.5.
Yeah. What's quoted is the quantum that it will buy in terms of additional sessions and additional care homes.
Is that up or down from last year?
It's probably broadly similar.
Very similar.
Broadly similar, because it's within the same budget envelope that we have, so there hasn't been an increased budget envelope for us to be able to do more.
I think it was 3.4 last year.
It could be different. I'll have to come
And
back
the
to
year
you.
before.
I'll have to come back to you, but 2.5.
Again, I mean, I think there's an important environment as well, and we had to acknowledge it up front, which our winter plans is to make the best use of the resources we have as effective as we can, acknowledging that we don't have enough resources that we want. And I do think as well, it's important to acknowledge that winter planning and winter preparedness and the activities don't take place in a vacuum. When there is an ongoing vacuum where we are aware of our engagement with general practice and the role of the GPs in terms of their concerns about negotiations this year, we're also aware of the position regarding nursing and consultant staff. So we're not naive. The winter plan has to happen in an environment, and that environment will continue alongside winter plan. But we're also, and I think Michael has hinted at it, we're also fully aware of the dedication of all healthcare workers, irrespective of the external environment, and they've all been engaged and working diligently to try and help us with winter.
And certainly that context that you're talking about is the possibility of industrial action. Industrial action happening at a time of heightened pressures, both with GPs and with other healthcare workers as well. Have you modelled any sort of worst case scenario for this all happening? Or?
What we'll have done, and it is referenced, is that at a trust level in particular, well, two elements. Obviously, as we continue to work with GPs, we have a contract in place, and there is responsibilities and requirements under that contract, so we expect the contract to be fully delivered. And it is very encouraging from the figures I understand in my discussions with GPs that they don't anticipate any reduction in the number of general practices who wish to take up this additional sessions and the additional work with care homes, because that is additional that we ask them to do. So there's that element. And the second element is that with all areas of the trust plans in particular, we've been asking them to look at scenario planning and continuity plan, and you'll be well aware this devastating impact of those, but you have to prioritise down from business continuity to emergency care to planning. So those are in place, which we would never want to have to activate, and I don't think either the workforce or indeed any trust management or our professionals would wish to activate those.
And it's to add, you know, we've had to enact those plans in the last number of years and on a number of occasions for different things, and trusts are well versed at having to go through, but obviously we need to wait and see the outcome. We clearly would hope that that's not a situation we're in, but we're mindful, and colleagues will be looking at how deep any action, if it comes, may be, and what is our response to that.
So
it will be very challenging. I mean, to come at the time of winter, it'll be absolutely damaging to elective care, and you'll have seen this week some really positive results that have been driven out of the system for our elective care reform. It will be a challenge, and one that we'll have to rise to as best we can and protect those who are the most vulnerable in society. But it's unfortunately been rehearsed before.
I should say, Danny, in terms of your question, the executive, whilst we've been meeting, have announced the 200 million for the pay uplift for healthcare workers.
200 million? Yeah, executive. Okay.
So just feed that in.
News.
But a good news in the middle of it all.
I take that.
Yeah.
That's great.
Yeah.
So you finished?
Yeah.
Okay, Dan.
Thank you.
Yes, thank you, Chair, and sorry I can't be with you in person. I have a ministerial visit to go to very, very shortly. So I think it's unfortunate we've had the sort of media and attention that we've had so far on the winter plan and on what I see as something a little bit separate as the big discussion. I used to be a teacher many years ago, and if I asked a student to write an essay, and they wrote me an essay which is a bit like this winter plan, which is a bit of sort of tell me everything you know about what we might do to prepare for winter, I wouldn't give that very high marks. I want something that's much more succinct, that tells me how we're going to cope in 4 weeks' time, whenever colds and flus and all sorts of things happen, and it becomes very, very difficult. And I was just flicking through the plan, and there's an awful lot of pilot projects that will kick in by March 2026. There's a lot of, there's a programme to pilot a geriatric assessment, which will be completed by the 31st of March 2026, a pilot aimed at increasing the availability of anticipatory care for those who need palliative care. There's an awful lot of this sort of stuff within the plan, and I would really have wanted to see a much, much more succinct plan that tells me how much money is available and what you're going to do to deliver something that really is a meaningful difference for patients and healthcare workers in these difficult circumstances. So my first question is, how much additional money in total is this plan going to be funded by? And how much immediate difference do you think it's going to make? So that's sort of my first question. The second area that I really wanted to focus on, and Michael's quite right about this, I have been asking for a long, long time now how we actually increase hospital flow, but to do that we must sort out domiciliary care, and particularly respite beds for those who are learning disabled, etc., etc. We had a debate in the Assembly on Tuesday about Woodlawn House in Dungannon, which is the main respite centre for the Southern Trust for adults with learning disability. March 2025, 24 short breaks were cancelled, 7 were shortened. Following month, April 23 were cancelled. Another month, 10 were cancelled. Is there anything in this plan that will make sure that those kind of things don't happen, resulting in people becoming sicker and not able to cope because they can't get any respite beds?
And I'll give a broad answer. I mean, I think our starting point, unfortunately for a lot of this, is we do not have additional funding, significant additional funding for winter. So a lot of it is about using the funding the best way we can. There is some additional funding, and Tracey will mention it, and some of that has been earmarked some of it has been earmarked or is being assessed for 2 of the areas you mentioned, which is short breaks and seeing can we increase learning disability and mental capacity beds. And there are business plans in process for 2 of those.
Jim, can I just come in there because I'm likely to forget. Sorry. The issue of Woodlawn was actually staff. They didn't have the staff to actually cover the respite. And in many, many care homes and for many domiciliary care packages, the issue is staff.
Yeah, you're exactly right. And I think we acknowledged at the start there's 2 big things that are driving capacity, and Tracey referred to them. One is money and one is people. And they're linked, but they're also not entirely linked, because we do have funding for people. It's accessing those. So I just want to mention those 2 as 2 specific elements that are within the plan. The other areas are about pilots that you've mentioned, and you'd like to see something more concrete. Nearly all, in fact, all the pilot activity is in our new areas of work, the big discussion. And that is 2 reasons, and Maria will talk to them. One, we're piloting, but it's from now to be completed by the end of March to work out, did this pilot have the desired effect that we want, and how do we scale it up? And the second is simply that it takes a time from June to work out what to do, to get those involved who are going to do it without additional funding and have the pilots in place. We do have some additional funding that we've had to target at those areas from the previous year and the information that we thought would make a real difference. Some of that is about domiciliary care additional capacity, but a lot of it is about ambulance handover and some of the GP areas. But Tracey will give some of the detail of that additional funding, but I think we can't lose the fact that we're saying we also need to use what we've paid for in the most effective way we can.
And if I can pick up one part of the question is about the plans, and I think that it absolutely is something that we will reflect on. But if you go to each of your trust websites, and we can make those available to the committee, each of the trusts will have their operational winter plan, which probably is the level of detail that you want to get down into. Most of them have a really helpful plan on a page scenario, so you can see it a real easy guide about what they're doing to manage admissions, what they're going to do to improve patient flow, and how they're going to deal with timely discharge. We are investing with our trust circa £10 million, and Minister has advised on that previously. But just to go back over what we're trying to do, so it's increased capacity at hospital at home, and some of that's where, for example, Northern didn't have that service in place. We're now equalising up, because what we're saying is we've learnt from last winter that it worked really well elsewhere. Why would it not also work in our Northern sector as well? So we should have that in place, actually operational on the ground in the next 2 weeks, I think. So we have invested in that. South Eastern Trust particularly have put significant amount of resource into that area, and it's working very well for them at the moment. We have additional short stay inpatient beds. We have additional step down and intermediate care beds. We have frailty assessment at the front door, and that ties very much into the learning that we had through the assessment. I mean, we know we have an ageing population. We know people are frail, but actually it really helped to drive down and how would we change that and what would we do to make a positive difference, and I think that's the difference from that. We also have expansion of our ambulatory and same-day emergency care, I mentioned earlier on, particularly in our western area where we've been able to go to 7 days a week. Now, some of that's about capacity and workforce, the same issue that we've mentioned with our social care. And we also have a multidisciplinary team assessment at the front door with our allied health professions and others, because we can see there's other ways and other professions who can help. We often medicalise and move it into that, and having others wrap round for appropriate care, I think, is really helpful. And then enhanced capacity for early review teams, and that ties into your question around, you know, community care and what we're doing. So we've mentioned before, but early review wasn't, again, across all of our trusts. It's in all of our trusts, and it's proven really helpful in recycling the domiciliary hours for the workforce that we actually do have, because getting more workforce is really difficult. But at the same time, the Social Care Collaborative are working with NISC about a career pathway and trying to show how valuable a career in social care actually is. You're right to ask about the real living wage. Minister's ambition is to move into that space. We are constrained at the moment because of the financial position that we are in, and that is creating some significant challenges for us in that ambition, but it is still our ambition. So those are the types of things that we put in and around £10 million within that. We also have, working with our ambulance service, working to bring in additional, a bit more novel pathways, so that we have mental health workers with our ambulance colleagues, and that really will help drive. So it's about them all working together to see how do we use everybody's resource to the best value that we need to. That investment, seeing on its own, is, you know, quite significant for us this year. We haven't had other money to really put into new things. We started with a 600 million deficit. I told you last period we're over 300. We're projecting maybe 325 is our maximum saving that we can do in that. If the announcement that's come through, that will certainly help us on pay, but we're still not in a financial break-even position. But we prioritised that because we absolutely knew that without something different this year, we were going to have the same or worse outcome than we had last year. So that has been the absolute priority for us, to try and to come up with all of the different elements. So in each trust it's not exactly the same because everybody was at different starting points, but what we've been driving in is to say where's the best value, where's the evidence showing us that we should go next. On the pilots, I would agree with Jim. It is a pilot that is ongoing, so it's actually on the ground at the moment. So you could say that some of the neck of femur work that I'm sponsoring at the moment is kind of pilot, testing out, is this the right thing? Will it get us what we want to do? But it's delivering today. We have seen significantly increased results for the 48-hour turnaround to get you through the hospital, have you operated on and get you back out to a general ward. I mean, it's amazing the results that some of the trusts are getting. We have moved from, in South Eastern Trust, we've moved from a 31% achievement to, from the April to September period, to 69%. You know, that's one of what we're doing, and we haven't finished yet. We haven't maximised out the potential of the project to really help drive it forward. But that was also supported with two different strands. Our efficiency programme, which we're already working on, and that's the performance management. That's the hard conversations that we have with providers and commissioners. And it's also with our elective care framework. So we can't see any of these things in isolation. So to say 10 million doesn't sound a lot of money, but we're focusing really hard. But when you combine it with all of the other things we're doing, we are really trying to drive as much value for this winter, and indeed the pressures day and daily, as we can.
Can I just ask another question? Oh, sorry.
Yes, go ahead, Dan.
She's muted.
Dan.
Technology's winning.
Oh. Okay, we'll potentially come back to Dan.
She didn't like the answer.
Is that a walkout?
It must be.
Hang on.
She's back.
Dan, are you there?
50p in the meeting.
My apologies, the dogs heard someone at the door. Of course, they had to make their voice heard. Just for me to conclude on this, because I do apologise, I have to run. Different trusts have different capacities. So you're telling me, for example, in the Southern Trust, we've been very fortunate. We've had an acute hospital at home service for quite some time. And the capacity and the knowledge of that service will be quite different to the Northern Trust. What will the capacity be? Will the capacity be enough to make an absolute real difference? In terms of ambulance handover times, one of the issues really around that was I do try to maintain a lot of communication, and they're very, very good, I must say, with the Southern Trust, which is my local trust. And I was over in September, and it's really important that they were talking about ambulance handover times. But the issue was that they had, about the day I was over, maybe 4 ambulances sitting outside waiting with patients. But those patients were being brought in one at a time and triaged, and then going back out into the ambulances because they still hadn't any space for them in ED, and this was the first week of September. So what are we talking about? How are we defining ambulance handover times? Is it that first triage, which then some of these patients are having to go back out into an ambulance, or is it the length of time in total that patients wait in an ambulance? And the other element of this is 10,000 care plans to be delivered in care homes by GPs. Have you an assurance that there is capacity within the GP network to actually do that? Is there enough locum GPs to do that or help with that particular process? I mean, I had a phone call 10 minutes after this was released on Twitter. I had a phone call from a GP actually in the Northern Trust who said to me, when are we supposed to do this? what will happen to the patients that we can't see then because we have to do this? And now I know you said that there will be additional funding for locum cover, but it seems to me that there will be an issue around capacity to actually deliver it. I mean, I do think it's the right thing to do. I actually think that caring for elderly, frail folk in a place where they know and by people who know them will ultimately result in better outcomes. And I think that that's important. The other point that was made to me was that unless there is a very expanded acute care at home service, if that elderly patient in a care home needs IV antibiotics, the only place for them to get it is ED or hospital admission in the Northern Trust. So it seems to me that it will be very patchy. It's about capacity and it's about ambulance handover times.
Happy to maybe to pick up first of all on the GP element. We'll have to test how much of that we will be able to gain over the next period. The local enhanced services, as I've said before, have come through the process with NIGPC, so we've had a level of engagement. We're absolutely hopeful that that is a realistic expectation. However, it'll be up to each individual GP practice to decide whether they take up the enhanced service. The enhancement letters, I think, we're going out today or tomorrow morning, so we will wait for the response on that. But it has been very well supported by our GP colleagues in the past. I visited with a care home some months ago where it was, a lot of that connection with your GP surgery, with your care home. There had been no admissions to hospital from that care home. I mean, it was quite a staggering result in a very, very long period of time. So if we can get it right, I agree with you, it's absolutely the right thing to do, but we'll have to wait for the process. So that will be part of the thing that we'll be watching and learning, but that's our ambition. We've tested it out with NIGPC. We have to wait and see whether all of the individual practices take it.
And it is fair to say that GPs who have been in contact have recognised this is an annual ask, have recognised the huge benefit and the huge importance to the community, and have indicated, I think, that they see this as an important part of a winter role that they play, and they have done for the last number of years, and hopefully again this year.
And I think on the handover, there's two points in that. I don't know the specifics of the example that you mentioned, but what I would say is the handover, there's a regionally agreed protocol that is being set out so that we iron out any of those difficulties. Is it handed over at this point? When's the clock start? When's the clock stop? Yeah. That's been worked across the whole of the region, and that document, I think, I'm looking to our colleague in the audience, but I think it's November very shortly that will be concluded. But it is when the handover of the care from our ambulance service to our hospital team takes place. But there'll be very clear agreed protocols on that as well.
And Chair, just very briefly on that, really important work around NIAS and conveyancing. We know, again, Maria mentioned the data, and joining this all up, if we look at the data, we know that 95% of individuals who are taken by ambulance to our EDs who have fallen are admitted. We know that many of those people have a very long length of stay, and because we're not getting upstream early enough, Maria mentioned frailty and early intervention, then quite a high percentage of those individuals never get back home. And that is something that we need to get ahead of. NIAS are taking some very innovative approaches in that space as a result of the work arising from the big discussion. And it is crucially important to improving our response time, our NIAS response times at Category 1 and Category 2 calls, that we free up ambulances that are waiting at ED, as Dan has said. At peak times, we can lose up to 2/3 of our ambulance capacity because they are sitting waiting outside ED departments. That is not effective use of skilled paramedics' time. It has actually significantly impacts on response times, and we need to get that fixed. And I'm pleased to say that we're making very good progress. Maria, I think you want to mention about the care homes.
Yeah, so I sponsor the groups that are looking at the care homes. So there's specific projects going on led by the Directors of Primary and Community Care, working collaboratively with other areas. But one of the examples just from the Northern Trust that I can share with you is where they've looked at the conveyance from some 6 of their care homes, and which had high conveyancing, and how they're going to have targeted teams around supporting that, so that actually they can support people to remain in the care home. And also in Belfast, we've got district nurses who are doing IV administration as well, Diane. So there's lots of really good projects that have emerged from this. But the really beneficial part is the sharing of the learning across the different areas, because this is a regional approach. So rather than everybody doing individual bits, the sharing has been really, really important. And the other one which we had sharing about is around the palliative care. So even though this is in the care home, we know that actually people living in care homes probably have a length of stay of 18 months to 2 years. A lot of the frail elderly people living with dementia, which is a life-limiting illness. And actually, they actually have higher levels of palliative care in care homes. They provide more palliative care than we do in our hospices, believe it or not. So we need to get in there and actually support them, and that's been very much identified. And in some areas, like the South Eastern Trust area, they have a register of everybody who's palliative in their system. All of the areas are going to take that on board. So that's been something that has come directly out of here, so we can identify in our communities who requires palliative care and get upstream in that, because the worst thing for anybody is to actually not be able to get access to meds, or people out of hours and be transferred in at the end of life into a hospital. It's wholly unacceptable, and we shouldn't be doing it.
Can I just ask one last comment? I again, over in Craigavon, and talking about pathways for people who come into ED, and where they had started a separate pathway to try to divert frail elderly folk into a completely separate area of ED, where they would be met by a consultant and a more holistic team that would actually deal with their needs. And it seemed to me that it was limited in space, because Craigavon is an older hospital with very little room, but it seemed to me an excellent way of trying to avoid this undignified, horrible idea of elderly people in corridors, on trolleys, dazed and not understanding what's going on, and getting them in and out of hospital much, much quicker. And those are the kind of things that I think, if we can roll out, will make a difference.
And Tracey will say, part of the plan, and I know our colleagues was released today, one of those is that approach has been learned, and it is part of the investment to allow it to be replicated in each of our EDs.
And I was actually in Craigavon myself last week, and I was really impressed by the commitment of the team in a very small space, and it is very, very challenged for space, and not, each of our emergency departments, each of our hospitals are not the same. They're neither the same age, the same size, they don't have the same size wards, and the commitment of the individuals within it to work around those challenges is very impressive. But I share your concerns. It is one of our oldest site ED, and it is a difficulty, and I think the conversation about our capital and funding and the difficulties we're having there, that all plays into that. They're none of the problems isolated in how we resolve them.
Just picking up on that transferable learning, though, but you're absolutely right, it's an excellent model, and I talked earlier about STEC, which same-day emergency care. It has been introduced, that model, under that approach in the Southern Trust, also in the South Eastern Trusts, and other trusts are actively looking at it, in addition to the respiratory, in addition to the cardiology, same-day emergency care. So it's an excellent model, and it links to a lot of the work that's coming out of the big discussion as well.
I was just going to say one thing which I think is really important, is that one of the challenges with the big discussion and the projects that come out of that is we've challenged people to do this within the resources that we have, which is actually doing things differently, and that requires change, a change management process, and also support for the leadership to do that within the system, and that has been very much part of the focus of this work, and will continue.
Okay. All I was going to say is, totally welcome the work on the palliative care. We've done an inquiry. The stuff that you're doing is elements of some of the stuff that we have heard over the last year, so it's important work. Dan, you're...
No, thank you, Chair.
Okay, thank you. Noah?
Thank you. Thank you very much for coming along today. I have a few questions and I'll try and keep my questions as brief as possible. Just first up, just to be clear, ambulatory care and the same-day emergency care, both the same thing? Yeah, just to be clear. And then ambulance handovers then. If we have people, and they're mostly elderly people then that are waiting in ambulances outside hospitals, and they are we are trying to meet a new target, which we should try to do. So of course we welcome that. And one of those elements is the same day emergency care or ambulatory care. Is the pathway still the same with regards to they have to wait to see a doctor like everybody else in A&E, or are people automatically diverted? Because we know when you come up to A&E, it's like it's a wait to see a doctor, it's triaged, but you don't know until you see the doctor that you're going to go to ambulatory care or be kept in. So,
and I think there's different routes, because again we have our ambulance colleagues, and for some of the areas you can move in our GP colleagues, some of the areas you can get straight through to, but there's also a pull from the emergency department. So what you've got is a team of people who are sitting looking at that first triage to see if you're appropriate, and it's an appropriate set of conditions to bring you into the same day. So I think it's a collection of those things, and you're right, we don't want to put anybody through the front door of an ED if we don't, but it's at that sort of triage point where they can make decisions about how the same day can help support those who are sitting on.
And is that already currently happening now in all of our EDs?
Yes, it all happens, but to different extents. And I think what you've highlighted and what Tracey's highlighted is one of the things that was in the strategic review. So in the operational review, what we're saying is let's maximise as much as this that we can get in every trust where it's there. So maximise it, which means you're pulled through ED into your same day emergency care. NIAS can do an assessment, say this person's suitable for ambulatory care straight in. Sometimes GPs can do it. In other areas, there's even a possibility of doing it through a method of phoning the trust direct. Yep. But we do know that the future is commonality of pathways and commonality of access. So in our strategy, one of the things that we know to look at was, first of all, maximise what we've got, standardise what we've got, then standardise the pathways into it. So it is a work in progress, and I think it's good to have all these. It's always difficult to describe to someone, well, how do I get into it?
And just on that, to give life to it, I mean, I think you have the expert experience in the room who have designed, developed, and are implementing these models, and some of the event today. They are all different. If you, for instance, in the Western Trust, slightly different. In the Northern Trust, you have somebody in ED who GPs can call straight. You have experienced nursing staff who will go actively into ED and will select individuals who are suitable. The slight variation, but it really is really impressive to see it on the ground. And again, some elements of this may be useful to give life to, words on a page are words on a page. Words on a page don't ensure that an ambulance is turned around quickly or ED, or somebody appropriately gets into STEC services. So again, I think it's nothing like seeing that in action.
So it's now taking place in all of them, and is that new this year, or was that in place last year? Did there have to be changes?
There's additionality this year, so there's expansion across each of the areas. Either could be extra hours, it could be 7 days, could be a new area, or really enhancement of, for example, respiratory.
Okay. And then, sorry,
I was just on the back of that is one of the actions that's come out of this is directories, because we do have variation across the piece and about how we can actually have directories for that. I know the Northern Trust, the South Eastern Trust are doing that this year. I would draw your attention to the PCC document, which has been really helpful in terms of planning for winter, which we have not done before, and that is saying that actually how we communicate this and the platforms that we use to communicate this, particularly for older people, we need to really look at that, and we need to do that for winter. So our comms people are already looking at that and how we can actually improve that communication, because that will impact how people come into the system. And if everybody comes in through ED, it becomes like a funnel for everywhere else. So we need to really ensure that we communicate that well.
And not all elderly or frail people live in a care home either, where they are being monitored. So it is very important. And just to go back then to the care home element, in the plan that was published today, it says that the department will introduce regional consistency in terms of protection of care packages, and so that is referring to the
14 days
cycle. Yeah. And we will look at the introduction of block home care contracts to address pressures. So I wonder if you could expand a bit on that, and is why is it we will look at it, or is it not needed yet, or what does that mean?
I might take certainly the start of that. So I think the challenge has been that we have tried to work through the conundrum of, particularly in rural areas, how do we actually generate the capacity to deal with the need that we have that's there. So for example, one of our trusts had been trialling a payment of an enhanced rate for a rural area, but actually the uptake was still not what we needed to meet the demand that we had. So the next stage of that is to say, well, if that doesn't work and we've tested it and we've tried it, are we into now a block contract to try and do something different? Now that conversation is ongoing with the Social Care Collaborative and with all of the forum that are there with our providers. So we have to find another way around. Will that be the only thing that generates the capacity? Potentially not. So we have to keep working at saying, how can we make this work within what we have? So it's about, we've tried something, and they're looking now at maybe geographically zoning areas. There, you know, there's a lot of real innovative thinking going around this at the moment, but a block contract for hard to reach areas may be something that we would need to go to.
And I mean that those discussions are happening with the providers.
Yes.
So the solution isn't just, we've come up with this, will it work? It's, and I mean, the description is, you make an assumption about how much you're going to need. You block book it in advance, so you're obviously at risk of over-securing practices, but you're also making something more attractive to say, okay, I've got a definitive package of work rather than a one-off domestic package travelling.
And it may be that it's, I suppose, a cocktail of different contractual practices depending on where we are. So, you know, there's been a lot of real thought around this about how do we make a change, because it has been a challenge and it is one of our major impacts on delays within our hospital flow system. So
I think the other element is when we're saying we're looking at it, if we look at it and it's going to work, the authority is to do it this year from Tracey's team. So
I think an important part of all of that is the type of bed, because we can block book beds, but actually a lot of the beds that we require are dementia beds, and that is more challenging to get. And we have a higher population of people living with dementia.
So what are we doing about that?
Sorry, I just missed that because Jim said something to me.
The dementia.
Yeah, the dementia packages. Yes, there has been, and actually some work with colleagues yesterday talking about even different rates for different programmes of care and how we might help to manage that. But dementia is certainly one of those. There's been a lot of thinking around that. And I think the home I referenced earlier, the visit with the really good GP links, actually it was a dementia care home. And, you know, we had quite a long, lengthy conversation about, you know, how we can manage. But again, we have tariffs, we have top-ups to tariff, we have individual packages. You know, it's all part of all of what we're doing in there. But I do think a dementia care rate, probably thought through, would be useful.
Okay. And the 10,000 care plans that are cited in the plan, are they the 10,000 care plans from GPs that happen year-round in the current capacity that the GPs already deliver, or are they related to an increased? Are they separate to the care plans, the 10,000 that GPs already carry out in care homes?
This is an enhanced service. So your care needs will change. So you will need to consistently be looking. So if you're someone within a care home, and you need to have your care plan, if it's not updated, then it's worthless for us. So it is about having that and having that additionality and refreshment.
It's also the change in the care home population.
Say that, I couldn't hear that.
Sorry, the care home population changes quite frequently, so there's changes over the course of the year.
Is that any increase in the resource for the carry out those care plans for the GP? So I'm just trying to ascertain basically as to whether it's, I know the care plans for the patients, but how are we going to actually carry it out? Is it additional for the GPs to do it? Will there be GPs physically able to do it? It's again going back to that process of how we introduce a local enhanced service. So when you go through a local enhanced service process, that conversation is had with NIGPC. The conversation there is about if this is what we want the outcome to be, here's what we think is a fair rate for doing it, and this is what we would hope to get from it. That conversation in two ways is then about whether it is broadly going to be accepted by the community, if it's pitched at the right level, is it doable, are the outcomes the same? So that conversation's been had, but we don't know until the actual offer letter goes out and we get it back in. That process is happening at the moment, but that's certainly the ambition that we would have for this winter. Okay, so yeah, I understand that now. So it hasn't, that isn't something that is agreed. It is a process. Is possible.
It is a process, yes, and that's part of what we'll test in our learning.
And you mentioned about research.
It has happened quite annually, so it's a tried and tested process of working out what is the amount that we would require to get this advanced service that we want.
And you mentioned earlier, Tracey, quite earlier on at the start, the elective care figures.
Yes.
And the Minister has announced that there was 100 million from his department has been found to add on to the 100 million from the Executive to deliver that 200 million that the Chair mentioned. But we were told in the Assembly recently and at every health committee that we can't deliver further. I mean, we had the trusts up to say that they couldn't find any money, and I'm really glad that people, nurses in particular, will get the pay awards from this year. But we were told that the money couldn't be found. We're told every year that money can't be found, and now we're told today money has been found. And when we had the trusts up, they outlined where their savings were in the trusts.
I'm not sure the specific reference, but I'll go over just where we are. So with a rejection of 200 million for pay, we would have had a deficit of 614. Yeah. We have at this point projected forward that along with our trusts, along with the savings at SPPG and department level or other arm's length bodies, we would get to somewhere around £325 million of savings. So we were short. Now that last sort of 25, so it might be the 100 in that's been talked about, that last 25 has just come out of this refreshed round of savings plans with our trusts. So we are still short pay, notwithstanding whatever announcement has happened while we're here today, so I'll pretend I haven't heard that for the purpose of that. So we would be still short pay unless we receive additional funding, and we are still short 75 million of breaking even on our budget, and that's with all of those savings going in. Now on elective care, we had 214 million was the figure that was quoted for elective care. That wasn't all additional money. That was about repurposing our baseline. So that was about it saying, don't spend it here, spend it somewhere else. What we have in that is we have 50 million additional that was non-recurrently given to us to support priorities for government, and it was really welcome, and we're trying to make best value. We had a further 85 and another 80, and the figures are not adding up. But we have at this point, there's one element of that we cannot spend because it would have increased our deficit. So we are spending our 85, we're spending our 50, and that's where we're driving out what we're doing at this point in time. And that's our Department of Finance colleagues are aware of. That's part of how we're trying to manage the savings, or we would have a £75 million deficit and pay and another 75.
But now we have the 75, another 75.
I think probably, because this stuff has all happened quite quickly, we probably want to consider the figures that we're looking at and the information that's released.
No, and I think it's important to come back to it. Like, and I think that's, to be honest, like, it's a difficult task for every single department within the executive, and it's really important that pay awards are made.
Absolutely.
But you know, it is also important to acknowledge that we do spend most of our budget from the executive on health, and we do spend more per head here than in any of the other regions, but our outcomes aren't any better. So we do need to change the system. I'm not saying as in you four sitting up there single-handedly alone, but it seems like we are pouring money in, the outcomes aren't getting better. We are told each year that there's these massive gaps that cannot be made. We cannot find money for staff, and then we do. So it makes me think, and
just to be clear, we within the Department of Health haven't found money for staff.
That is what the Minister has said today in the press release, is that the Department of Health has.
We haven't found money for it. The figures I'm telling you are the figures that we have, 325 and 400. If we have, we may have been receiving additional money. I don't know what the comment is.
Okay.
That's the position.
Well, probably then best if we come back to it, if we don't, if it's happening.
But I think the general point is correct. I mean, when we talk about the Minister's 3-year plan and we talk about the reset plan, we've always been clear that there are 3 elements to it. One is stabilising the system, and you stabilise the system through your workforce, so pay is a big important part.
Absolutely.
But the second was about poor performance and efficiency, and to do that we do have to be honest and say we've got to judge ourselves against what is delivered in similar circumstances elsewhere, and that's why we use that GIRF data. That's what's driven the emergency care, that's what's driven a lot of the electives. So when Tracey talks about we've got improvements in elective through spending wiser, and therefore some of the ring-fence funding, we've met those targets by being more efficient. That is meeting the targets, but it's doing it by being more efficient rather than necessarily purchasing more activity, which gives us some headroom. So I think it's a very fair point, although I also add, in all the fiscal studies, it also mentions Northern Ireland has the highest need as well. But your
And
point's well made.
that's why I was asking about the elective care figures, because I think that is important. And the figures that came out, I think it was just yesterday.
Yesterday.
On tackling waiting lists, in particular, using the elective care kind of hub and framework. And what would the expected delivery? And we know targets can have targets. We don't always meet them. Like, we know that it's unrealistic. But what would the expected delivery now be in terms of that elective care figures? Because I think, was it 100,000 I read?
Yeah, we're certainly pitching towards that number, but we with some of the efficiency gains and some of the work that we're doing at the moment, we're really trying to push as far as we can. We want to reduce, I mean, in simple terms, we want to reduce those very long waits, and we had sort of drawn a line, and I mean, we are significantly more than 4 years, unfortunately, at the start. So we're bringing those down. We're trying to drive as much through the most efficient models, having our mega clinics set up, having whatever way we can do it to drive in the capacity of the system. So I can't give you a number now because that is changeable, but it also depends on the capacity of our workforce to deliver additionality and the capacity of our independent sector to deliver additionality, as well as us driving the efficiency of what we have on the ground, maximising our theatre run times, maximising and reducing, clinical variation. So all of those pieces are in the jigsaw, and it's very hard for me to give you a number, but they're all running at train at the same time. But significant effort behind each of the strands.
Okay, thank you. And I think maybe if we could come back another time around the finances, and I think more detail on the social care elements, I think is important.
Yep. Do that.
Alan?
Thank you, Chair. Look, I've never needed to be convinced of the value or the benefit of taking up the offer of vaccines, and I've certainly encouraged everybody to avail of whatever vaccines are available to them, and obviously it's a way the public can play a small part in taking the pressure off the health service over coming months. But my question is there any evidence that vocal anti-vaxxers are having any adverse impact on the uptake, or is uptake remaining steady? And I'll go straight in then to my second question, which is a different issue, but in this document, you've quoted the big discussion where you said that between March and June 2025, stakeholders from across the health and social care system explored learning from winter 24. But over the last 24 hours, I've heard a lot of very adverse and very targeted criticism coming from commentators, coming from the media, coming from individual stakeholders and others that you really should have been started doing your preparedness back in the spring. So how would you respond to that criticism, which is obviously quite misinformed?
Well, I suppose if we go in reverse order, I'll do the reverse one. All our preparations did begin in spring, so the big discussion started in spring, and the separate work that Tracey's team were doing with individual trusts, with that detailed learning plan, including the arrivals, the pressures on ED, started with what would be done regionally to support what are the emerging trends, and we talked about it, care home packages, ambulance handovers, and congestion in EDs, what could be done and how we would prioritise that. And that informed both the trusts' individual actions, which we've been able to list some, for example, that those trusts that have put failed the assessment at the front of ED, that have got different units. It also reflects work with NIAS. So all that was happening, and I suppose that was one of the concerns really today we wanted to get across to the public, that the winter preparedness plan is a plan which tells what has happened and been prepared and the work that's been done, and that has been happening since March. And I mean, the people who are doing that are actually the clinicians, the directors of operations, the nursing staff, all who have been contributing to those plans to identify what do we need to do and what can we do better, as well as colleagues in SPPG. So it is concerning that, and I think everyone has quite rightly pointed out we need to think about how do we communicate the difference between preparing and planning and publishing a plan to tell you what we prepared and what we planned. Because if people are concerned that the plan is the element that triggers preparation for winter, then publishing in October clearly isn't a good message to the public, thinking nobody's doing anything until they know what to do. So that's a lesson that we've learned. I know Michael wants to say something.
Well, in terms of that, I think it shows that criticism was not only misinformed but grossly unfair.
Well, I mean, if I could maybe just add to that, I mean, I think it's you know, as we said earlier, I think it's a disservice to all the hard work that's gone in by those working in our trust, those working in primary care, or those working in community services, those working in care homes, and the joint-up approach that's being taken. I think that's unfair. And it's not a fair representation of the effort that's gone on, and certainly by departmental colleagues, and certainly colleagues within SPPG, and indeed colleagues in the Public Health Agency. My fundamental concern is, you know, if I'm 85 years of age, sitting at home, and I have an underlying health condition, and I'm depending on perhaps needing access to my GP or access to acute services, or I'm a carer for someone who may be vulnerable, then it sends all the wrong messages. So I just want to reassure the public and just correct that disinformation that this is just planning and preparation starting now, and that there hasn't been engagement across all professional groups. There has, and I'm very, very grateful to all professional colleagues who've very actively contributed to that, as has been said by Tracey. Just in terms of your first point, we have worked very closely, our Public Health Agency colleagues have worked very closely with the UK Health Security Agency and other public health bodies in Scotland and Wales. We have really good data from Royal College of Paediatrics and Child Health, for instance, that shows that vaccine hesitancy is not a significant issue, as many have been indicating, that there is, again, a very high confidence in the public, around parents and in adults in relation to the effectiveness of vaccine. We do have more work to do, however, in terms of improving accessibility to vaccines. We need to make it easier for people to access vaccine. Now, we have a very effective vaccine programme each year involving obviously our colleagues in general practice, involving trusts, involving the school nurse teams who are vaccinating in school, health visitors. We obviously have community pharmacy working and paired with our care homes. So again, we have a very effective programme which uses the range of skills and experience of many providing health and social care services. I do think we need to be particularly mindful of the fact that there are individual groups within our society who perhaps are new to Northern Ireland, where English may not be their first language. We need to work much more proactively in outreaching into those communities. We know that there's lower uptake in some areas of socioeconomic deprivation. We need to take a much more targeted and focused approach. Public Health Agency, working with our colleagues in general practice, working with our colleagues in trust, working with colleagues in the department, have again set up several groups to look at the research evidence, which is actually perhaps, and some of the barriers that may be getting in the way, are very actively progressing that. And I'm hopeful that much of that work will be manifest and translated into targeted action intervention this winter. Separately, again, our Public Health Agency is working with Queen's University to basically understand what more we can do from a behavioural science approach to ensure that more of our frontline health and social care workers avail of the vaccine. I suspect a lot of that, again, is around access, but we have work to do. In terms of vaccine skeptics and media, I think the thing what we do know from all of the research is that you correct disinformation and misinformation with facts. And that's what we will continue to do. We'll basically point and continue to point the public and others to the factual position, to the evidence base, to the safeguards that we have in place. And that's, in my view, and the research would show the best way to deal with that. And please, just finally, I would encourage everyone who's eligible for a vaccine this winter, please help yourself, protect your family, and actually help everyone who's working in the front line in the health service to do their job.
And I would fully back that as Chief Nursing Officer.
Thank you for all that you do and all your colleagues do.
Thank you.
Okay, thank you. Alan Robinson.
Thank you, Chair. Can you hear me okay?
Yep.
Thanks, Chair, and forgive me for missing today's meeting in person and missing most of the meeting. And again, forgive me for a third time for potentially maybe missing in some of the answers that have already been given. One kind of quick sort of speed read for about 6 minutes earlier when the document appeared on my email. And one of the sort of very striking commitments that I read on page 5, and that was the piece about reducing ambulance handovers from 4 hours to 2 hours. It's a very bold commitment, that. And I was just curious, given that we're already 6 weeks into that commitment, because it details from September to December, have we any hard figures of how that commitment is progressing and how it's faring?
Yes, I can give you some detail on that. So at the end of September, and that's the first month where we've been pushing in, we have 4 of our hospital sites managed within less than 1% going over the 4 hours, which, you know, that could be a minute over 4 hours, it could be, you know, an hour over 4 hours. But that was the Royal, the Mater, Southwest Acute and Daisy Hill. And we had a couple of our hospitals then, 3 of them that sat within 5% of meeting that 4-hour place. And we've had 2 who have been 9% and more significant. So for those 2 trusts, and that be North and South East, we are working with the senior teams there to see what other support can we do to help. They're under pressure. A lot of what we've put into the new investment for this winter should assist, but they are areas with high levels of demographic growth for older people, so we shouldn't be almost surprised that they are having significant challenges. However, we need to all find a way to collectively work together. So my colleague Lisa McWilliams and I met with Chair and Chief Executive and Director of Ops in both of those trusts last week. You know, I'm completely assured of their commitment and the senior team's commitment to do better, but it is a challenge, and it will remain a challenge going over this next period. Some of the investment coming in will help, but I would say that it's been really great performance by a number of hospitals who have already got to that position. They'll have to maintain it and they have to improve it, so it's going to be a challenge over this next month, but kind of had a letter from me at the end, noting the performance, noting where we are, reminding where we need to go, and as part of the visits that we'll be doing around the system, we'll continue with our staff to try and support where we can. We actually had Getting It Right First Time, the GIRF team back, looking at a couple of our hospitals, and a particular comment made in the south about the progress that was made in Daisy Hill, and I think that's tremendous. They had no ambulance over 4 hours, which was really excellent performance, and where there are other areas, they're pointing to other things, same-day emergency, how can we make it more efficient, how can it assist, how do all of those other elements do. So look, it's a mixed picture at the moment, but it was a mixed picture to begin with, but the commitment for us to help in that and to really drive down has been agreed regionally, so we need to do all that we can, and I'm assured that all trusts are taking it seriously, and all of the clinical and professional teams within the trusts are doing what they can to move this forward.
Obviously, Tracey, one element of the throughput this would greatly benefit, so it's a bold commitment that I certainly would very much welcome. I hope that we do see the benefits from it. Just on that, I assume as part of that, I know you referred to the trust, but the discussions you had then with NIAS with regards to this commitment, what was their response? Because I know what they have told us in the past of the pressures that they have faced, both on staffing and obviously the wider hospital pressures. What was their response whenever this commitment was inserted into this document?
Yeah. So our NIAS colleagues have been absolutely engaged, both with our other trusts and with ourselves, in looking at this from a regional perspective. So we know the impact that it's having on NIAS staff and on their ability to meet their performance targets, which is an issue. So we have to help them solve it by making the system move more freely. So NIAS are absolutely wedded in. We had a regional workshop at the end
August. 25th of
I was
August.
trying to remember the date. It was the end of August, where we actually collectively were all together, and we had colleagues from London who have done this.
Yeah.
And I didn't see anything from them that we don't have here. So in terms of all of those component parts of flow, but it's about how do we maximise them, how do we make sure it's working as best we can every single minute of the day. That is a real challenge for our staff, constant. So I think that it's a good start and very positive progress from a number. For those that are struggling, we're wrapping around them, and we will support, but we will also do our role in holding to account to try and push as far as we can.
Tracey, that's a useful example of, to illustrate the preparations that take place, because the initial exploration, I think, or consideration of a London model happened and was discussed, I think, in spring, followed up by sort of detailed visits to that London opportunity with clinicians, with NIAS, and with commissioners to see what could be done, followed by a workshop to say, is there anything missing that we couldn't do here, resulting in the commitments that are there, also testing that those commitments are really, really stretching, hence we're not making them straight away and there's work to be done. But that is the process that produced those targets in this plan, and the work that's happening this month, next month.
I mean, just to say, it was a very joined-up approach. The four of us were there, senior leaders, senior clinicians, senior nursing staff, social work staff, were in the room, because this isn't, you quite rightly said, this is not an IAS problem to fix. This is a system issue, and it requires all of us to actually commit to that. Maria,
and one of the key things, I think, is the conveyancing, and I'll go back to the point of that you have to deal with all parts of the system. So if we're conveying people in, that's taking up an ambulance, and especially if we're conveying people in where the treatment could be actually delivered elsewhere, and that is a real focus of the work that we're doing.
And also just ask, again, it may well have been covered, on page 4 of the plan, it makes reference to increasing capacity within GP practices, obviously to absorb the winter demands. How many sessions, it refers to increasing the number of sessions, how many sessions will that be?
And I've pushed over my page, so I can't remember, and I'll make sure I get it right again. So I think it's 10,000 care packages and 8,000 sessions, additional sessions over the winter.
And again, the response from the BMA to, again, we get it hot and heavy from both GPs and the BMA, that whole wider GP sector. What was their response whenever, again, this was inserted into the plan?
And we probably had a bit of a rehearsal, but just the process for us bringing these in, these are enhanced services. There is a well-trodden path of managing that from SPPG colleagues who manage the GP contract to our NIGPC colleagues. So we write up with the benefit and support of the GPs who work with us as medical advisors. That's sent out for consideration by NIGPC colleagues. They get a chance to write that back to us, and we consider, and then we issue the LEAs. Then it is up to individual GP practices as to whether they take up that LEAs or they do not. So that process has been a process that's been in place for many years, and we go through. So the engagement is through that route on that operational issue. So that's how we do our engagement with our GP colleagues on those enhanced services.
So Tracey, would you tell me then that this enhanced services are effectively out of hours services?
Sorry, I just missed that last bit.
They're a new additional service to what's in the standard contract.
Additional services?
Yeah, not out of hours, just additional services.
Additional.
Okay. Okay, right. I'm surprised to hear that, because given, as I say, the pressures that we're facing from the GP sector, and they tell us that they can absorb no more. But anyway, can I also just ask, obviously the Minister had cited some good news yesterday, where he hailed, or he made reference to waiting lists and the improvement in those waiting lists. And obviously we don't want to see that going backwards. And again, forgive me if I missed it within the document, but does it make reference somewhere or anywhere about elective care and how that will be protected?
It does, and my colleagues try and find the page that it is. But I suppose, even if Jim finds it, what we explained earlier is that, while this is about the unscheduled care pressures and our community pressures, it can't be seen in isolation, because as we drive down the waiting list, sorry, page 21, Jim has indicated, but as we do that, we need to also be driving down our waiting lists so that people get in, get the care they need, who are not on a waiting list longer, who don't need social care for longer, and maybe deteriorate and then need further care. So all of these things have to happen, drive forward at the same time with the same pace and urgency, so absolutely connected.
I just asked as well then, just obviously this plan is being stress tested as we speak at this present minute. How optimistic are you that this plan will be effective?
And again, we probably rehearsed that a little earlier, but what I'm very clear, the system at the moment is under sustained and quite severe pressure. That's happening today. You saw it in the summer. We all know that that's happening day and daily, and a challenge for our staff. What we have done with a very small amount of funding, given our financial backdrop, is to invest in the places with the best evidence, or to test what the full system agreed is the right things to do to try and make the best value of that. None of us here in the panel will say that we couldn't have a challenging winter. We don't know when COVID might spike, we don't know when flu might spike, and we don't know how deep and how hard. All of those things last year, when we go back to when I came in January, those were the things that really beat us, about things all coming in one go. We have a set amount of capacity. We can stand up about another 250 beds, to manage what we do across our site, but we're using those a lot of, on day and daily at the moment. So we are trying to spread as far as we can, to be as efficient as we can across the system, and invest wisely with social care through our hospital system to manage our flow and get people back to their homes as quickly as we can. So there will be an impact, but there'll be other factors that we'll have to watch. So with our public health agency colleagues, we are constantly reviewing the surveillance data for flu and other illnesses, and it is still going to be a challenge, but this should give each of our providers the best chance of making the best impact with what we have for this winter.
And again, I think we did rehearse a bit that the winter plan and no winter plan, and including even the activities under big discussion, are a silver bullet, but they're all researched, agreed and targeted incremental steps to try and improve system and mitigate to some effect the impacts. And we also are of the view that some of these incremental steps, if embedded and becoming mainstream, could have a longer term solution, particularly around some of the frail elderly issues and challenges.
Okay, just maybe one other point. I think maybe it was Nuala maybe made reference there about the nurses' pay announcement. I see it on the wires there. And the Minister yesterday talked up again about the waiting lists and the improvements therein. And he made reference to potentially money may not being required for waiting lists as he thought it would be. Did he mean by that some of that ring-fence money could be moved towards nurses' pay? Effectively, like Rob and Peter to pay Paul?
And we will go out and we'll set it out in a paper. I think that's easier than me talking through numbers. But we explained 2 weeks ago when I was here with Permanent Secretary that the £215 million of the waiting list money, we were not spending it all because we were in a financial deficit. So that was already plugged into our savings plans and agreed with the Department of Finance. So it wasn't an element going, if you like, to nurses' pay, to put it in those terms. It was an element to help the department manage its break-even duty. But I think clearly there's things in the wires as we speak, and I think it would be fair to allow us to send you in a summation of that after.
Whatever the news is, and if there is good news in nurses' pay, that is to be absolutely welcomed. I think all of us. If that is the closing point today, then I think that is a very positive note to end on.
Okay, if it's on the winter preparedness plan, yes, go ahead.
It is. I told them it's not controversial, but let me back in. But it's something that I did notice in the plan, and something that's really important and none of us really talked about is children's care during the winter months, because I find myself at A&E. And particularly in the Belfast Children's Hospital in particular, they do get quite overwhelmed as well. And there's some reference into the out of hours, but what steps will you be taking specifically to that age group that does go into A&E, and it is like the likes of strep or colds, viruses, and it is overwhelming the staff there, and it's a natural worry for parents. What more is being stepped up in the out-of-hours service that can prevent that flow?
So in the paediatric emergency service in particular, this is one of the first times it's featured as a standalone.
It is a new element this winter.
Of the winter plan,
and
where we've got
to be welcomed.
A child health partnership group has set up a winter planning team, and that winter planning team is actually a proactive, active winter planning team that will operate on a daily sit-rep approach. Look at where the pressures are, look at discharge, look at managing pressures, manage the service on a regional basis, as well as, I think critically, and we've mentioned comms a lot of times, sometimes the best comms come from the experts who know what's happening. And one of their roles will be to provide that children and child-specific communications around what to do in terms of winter pressures and concerns about emergency care. So that is a new area within the plan, and it has emerged, driven largely by clinicians and the PHA, saying this is something that we can do and we believe it can bring an impact to the service, and working differently. So it's one of those working differently rather than massive investment tools, but it merited reference, and that's why it's there.
I mean, it's making best use of the regional beds that, as you say, are in sick children's, and there are obviously other paediatric services in other hospitals, and it's also a key element of that is minimising the non-clinical delays for individual children, and that obviously through enhanced of the retrieval and transfer services and extended hours into twilight hours, which is a significant undertaking because it's a very specialist service requiring consultant medical cover, very senior experience, advanced practice nurses. So that is, again, a new thing this winter, which we hope will ease some of those pressures.
Okay, thank you.
Okay, thank you. Thanks very much to the four of you. Now, given our very first part of our conversation about maybe additional questions once we get further time, what I'm going to suggest is we may, in the first instance, write to you if there's additional questions. And let's hope everything goes as well as it can go over the winter. So thank you very much.
Thank you, Chair. Thank you, members. Thank you very much.
Okay, members, there's no other business other than just the date, time, place of meeting, which is next Thursday, 23rd in room 29. So thank you. Can I thank everybody here for their attention over that period? Thank you.